please take the stage Dr. Mohammad Monoarul Islam. Thank you.
Would you please share the slide? Yes, thank you. Dr. Alad. I think all of the panelists already in the dais. Professor Bishwajit Bhowmik, would you please come to the dais? So, welcome to you all in our next session, Managing Pelvic Recurrence and Breaking the Barriers. I am Dr. Monoarul Islam Masum, Assistant Professor of Colorectal Surgery working in Shohid Sardi Medical College Hospital. I will be discussing on the case and a comprehensive discussion in different point of discussion will be made by our honorable panelists. So this is a story of December 2022, when a male patient of 54 years came with the complaints of rectal bleeding for 6 months. Abdominal examination was normal, and on DRE, there is an anteriorly placed firm exophytic rectal growth 2.5 centimeter away from anal verge. This is the colonoscopic picture. Here we see the ulceroproliferative growth. It extends from anal verge and another polyp in the 18 centimeter. The rectal growth biopsy showed moderately differentiated adenocarcinoma, and polyp was just a tubulovillous adenoma with low-grade dysplasia. Serum CA was within normal limit. And if we see the local staging of this patient, this is the MRI of pelvis. Here we see this rectal growth arises from about 2.5 centimeter from anal verge, and you see here is a lymph node present. This is stick to axial phlegm. This will be later on discussed by our honorable radiologist. So this is a growth, and MRF is not involved actually, and EMBA present. This is the DW phlegm, and here we can finally found that there's clearly enhancements of some lymph nodes. This is the lymph node and many other lymph nodes in different points of this video. Due to time limitation, I am escaping this. So the report is 2.5 centimeter from anal verge, there is a growth. MRF is not involved. At 3 o'clock, there is EMBI, and this is T3B N2MX tumor. No distant metastasis are found on CT, chest and abdomen. So at this stage, this is the scenario, locally advanced rectal cancer, and this is the lower rectal cancer, 2.5 cm from anal verge, T3B N2MX, EMBA positive. So first of all, I would like to draw attention of Dr. Alauddin Marui here. Here you see, this is the lower rectal, locally advanced rectal cancer. And there is two issues here, N2 positive and EMBA positive. So as far as we concern here, there is chance of local failure as well as the systemic failure also. So in UAE, how would you personalize when you schedule for a TNT for this patient, whether you choose induction or consolidation, and how will you personalize it? Dr. Alauddin Marui.
Yes. What is the definition of learning? Is changing behavior. So if we get some new information, maybe that would change our behavior. So in this case, it's low rectal cancer, right?
Yes.
Chances are whatever you do, he's going to lose his sphincter, and he may end up with permanent colostomy, right?
Yes, maybe.
Most likely. And this is why I think, your case 2022, but if we can do it now and do this mismatch repair immunostain, that will be great. Why? Because what if he is lucky, like one of those cases I showed, where he can end up with complete response and maybe you can spare his sphincter. But practically, it doesn't sound like it's going to happen. Anyhow, those are only 5% of cases. So assuming that he's not from that category, okay, you have now you already staged him, and he is stage 3B, correct? I believe.
Yes.
Okay, so you have to proceed with chemo radio, followed by adjuvant. So it's just you're going to have to do the standard treatment. Now, regarding the future, who knows really? I mean, you'll do your best, and then you're going to have to monitor him. So it's really hard to tell, but he has, I would say, around 30% chance of disease returning. And this, you may have a stage 3B disease with small tumor. This tumor is big, so
Yes.
Chance of also local recurrence is high. And I think I'd like you as a surgeon to do total mesorectal resection.
Okay. So thank you, sir. And here, Dr. Jayed Khan present. We surgeons are very much fan of your ESMO guideline because we, especially in the mesorectal cancer, we go for a short course radio and go early surgery. But if we recall the Rapido trial, the short course TNT, if we consider, then initially the result was the good, but after 5 years, there is local regional failure was about 10% in comparison to conventional CRT, then surgery followed by adjuvant chemo, where it was only 6%. So in UK, if you schedule this patient for the TNT consolidation, what is your opinion of the short course TNT? Is it possible to personalize for this space, for this case actually? What is your opinion?
That's a good question, and I'm not sure there is any an answer that I can give will be accepted by everybody. So, as I mentioned in my presentation, that increasingly we are actually using the Prodigy type approach in the Rapido patients and Rapido approach in Prodigy patients. So this patient has got lots of risk factor, low cancer, large in size, node positive, EMB positive. So definitely there is indication of multimodality treatment. Now again, if you mention ESMO, then I'll go back. The ESMO has actually stratified patients to whether surgery is the intended goal or the organ preservation intended goal. Now regarding the radiotherapy choice, I completely agree the higher local failure in the Rapido group, and which has made some people nervous about the short course. So if you're concerned about that, the long course is certainly the reasonable option to consider. But that doesn't completely rule out, not everybody may be a suitable candidate for long course, and some people may have contraindication to chemotherapy or compliance issue. In that case, short course is still an option. But I think I would agree with this approach with the long course chemo-rad. And obviously I agree with Dr. Marawi that the MMR or the MSI should be done to make sure that we are not missing the opportunity of an immune checkpoint inhibitor.
Okay, thank you. So this is the reevaluation MRI of this patient. And here we found the growth is regressed and no lymph nodes. I'm escaping DW MRI. And re-evaluation MRI report is growth is now due to shrinkage. It is 4 centimeter from anal burst and T3A N0 MX. So this is the MRTRG of before and after TNT of this patient due to T2 sagittal flame. Professor Bishwadip Bhomik, sir, as far as we are concerned about the distal dissection margin, so would you just comment on the distal margin before and after TNT? Professor Bishwadip Bhomik.
Thank you, Dr. Masoom. So in this field, actually we are here we are seeing the first film, the tumor is significantly bulky, and the second film, the tumor is significantly reduced in size, but it's still in touch of the anorectal junction here.
Yes.
So I think the tumor still is in contact with the in this anorectal junction. And can you please show us?
Yes, this is the T2 axial flame.
So here we are seeing this is the before TNT. The tumor is bulky, and after that, and the tumor is smaller in size, but still, can you go a little bit lower?
Yes, that is the DW MRI.
Okay. So here we can compare the before the TNT, the
Enhancement.
Restriction is significantly larger area, and there is all this small area, and after that there is only small area which showing the diffusion.
So we can conclude
restriction.
here that this is a good responder tumor, probably the MRT is a grade 3, and this patient, due to shrinkage, lower margin is now in the 4 centimeter from anal burst, which was previously 2.5 centimeter from anal burst. And again, the re-evaluation CT abdomen chest is normal. These patients in abroad, they done a robotic ultra-low entry resection with diversion loop ileostomy. I would like to draw attention of our colorectal surgeon, Honorable Professor Shahadushan Sheikh. This patient had undergone anterior resection ultra-low. That is, they, in their operation note, they said that they think about the distal margin after TNT, that is now in the 4 centimeter from anal burst. If you see this picture, here, the pre-TNT, this was the lower limit of growth, and after TNT, this is here due to shrinkage. And their surgical plane of dissection margin was this red line. That is, they considered the after TNT the lower margin. But should we consider the lower margin after TNT or the previous side? That is, this is the green line where if we could consider this green line instead of the red line. What is your comment of surgical plane?
Actually, practically we should not. We should always consider the previous lower limit, because upper limit can be only considered. It's little controversial, because if you think about the CCR, when the initial whole tumor is there and after total therapy, there is CCR and we are going for the observation, so that we think probably there may be path CR, but all CCR are not equivalent to path CR, we know. But if they consider, because this area within the 1.5 centimeter, probably some nest of tumor cells still might be there.
Yes.
So for the R0 resection, we must consider the initial assessment of this patient.
Yes.
This is my opinion.
Thank you, sir. This is probably the nest of the cell may remain here. If you see the red line, it may have no cancer cell. It is discontinuous, but there may have some cancer cell here. That is, the Professor Sheikh mentioned about the nest of cancer cell may remain in underneath the red line. So better to go for this green line, that is before TNT lower limit. And if we see some evidence, this is the disease of colon and rectum journal. They are saying, are we dealing with an invisible margin? They used a clock flash template on the resected rectal cancer specimen, and they found that tumor cells scatter after neoadjuvant therapy. You see here in the different clock position, there is 1 cm, 2 cm, even 3 centimeter scattered cancer cell outside the visible macroscopic margin. And their conclusion was the almost 50% patient with residual tumor after radiation had tumor cell found outside the visible ulcer. That is microscopically found, not macroscopically. So if we critically analyze their result, then we can say that 50% patient may be fortunate enough, they might not get involved DRM even if you consider the post-TNT distal margin, but 50% patients may be unfortunate with DRM involvement. But in this case, we surgeons and oncologists are unfortunate because this patient had not received any histopathology report so that we can conclude the whether DRM is involved or not. So this patient, adjuvant 2-cycle capox received, ileostomy closure done, this was on the regular follow-up. And after 1 year and 2 months, the patient has no complaints at all, but on a routine DRE, the anterior placed ulcerated lesion was found below the staple line. Proctoscopic biopsy says moderately differentiated adenocarcinoma. And at this point, as our panelists said, the immunohistochemistry was done, intact clear nuclear expression was found. And this is proficient MMR, what I say, that is microsatellite stable tumor. So this is the re-evaluation MRI at this stage. I am not showing for time constraint. This is the growth. I am escaping again this video. And MRI abdomen also done, and you see there is no metastasis in the liver or any ascites, so there is no distant metastasis. Again, it is a locally recurrent rectal cancer at this stage. So MRI report showed a recurrent rectal lesion below the staple line in the rectum anterolateral with mesorectal fat standing, no lymphadenopathy. So what the report says, we can conclude that this is an easily resectable, locally recurrent rectal cancer, interluminal recurrence. And CT abdomen and chest is normal, CA was normal limit. At this stage, I would like to draw attention here, our radiation oncologist, Dr. Morganti. See, this is a locally recurrent resectable rectal cancer actually. This patient is microsatellite stable. And initially,
Posso parlare un attimo?
yes, initially this,
Posso parlare anch'io?
yes sir,
È un esame o
sorry,
is this a discussion?
yes,
No, thank you.
okay,
So about the previous slides,
yes,
among consolidation and induction
yes sir,
chemo radiation, in a tumor so large, so huge, I would have preferred, as they did, chemo radiation before. Because in this way, the distance, the time interval between chemo radiation and surgery is longer. And this gives us higher chances of clinical response. And this is one. Second, you were citing the study showing that 545 produce more recurrences compared to standard chemoradiation. Consider that subsequent analysis shows that this difference is true only for patients treated with old radiotherapy technique. In patients treated with IMRT or VMAT, there is no difference in local control. About this situation, okay, is resectable. For what I know, it's a locally recurrent rectal cancer. Can be small, can be big, can be high, but the prognosis is poor. So I would consider to irradiate the patient.
yes, thank you sir, because this patient has initially received only 45 gray and it is about 1 year and 2 months after the previous radio. Dr. Gunaratne, are you, do you have similar opinion like Morganti, or do you want to say something others?
So now is the already recurrence. So uterine is seem to be operable.
Yes.
But anyway, I want to discuss with surgeons is maybe the permanent colostomy or just removal of the tumor. So in that case, I want to discuss with the patient what about the your idea. So sometimes most of our country, most of patients they refuse for permanent colostomy. So in that case, there's a problem. Then I will ask from, I think about some re-radiation that's possible after 1 year.
So you're going for re-irradiation.
Or in addition to that, I will give other purposes, I going to the chemotherapy if the patient is not willing for permanent colostomy only. Otherwise, if it is resectable, easily resectable, I will go for surgery too.
Thank you. So if we see some evidence, this is the papers we found in this year in the practical radiation oncology group, the re-irradiation, the management of the locally recurrent rectal adenocarcinoma. Here we found some answer of the questions that is there any rationality of the re-irradiation in the resectable rectal cancer? Answer is yes, because the surgery is very much challenging in the recurrent rectal cancer, because locally recurrent rectal cancer itself is infiltrative in nature, and post-radio and post-surgery fibrosis is used, though surgical plane may be missed, and re-irradiation can be helpful to avoid the scattered cancer cell and taking it in the TME specimen. So are recurrent cancer cells are radiation sensitive after prior radio? Yes, because there is no difference between primary and recurrent cancer cell. And what is the suitable method of re-irradiation? So Professor Morganti rightly mentioned, and hyperfractionation probably will be good, and accelerated hypertension is now used. EBRT also can be used. They mentioned about the dose, the 30 to 49 gray, and importantly, the interval should be at least 6 months from the prior radio, and 1 year is the better in some center. The very important issue is there any toxicity with it, Answer is this toxicity limit is tolerable. This is the toxicity tolerable limit, because most of the center found that the 0% grade 4-5 toxicity and grade 3 toxicity is only 5%. Even this NCCN has mentioned about their tumor boost radiation and their small bowel maximum point, which was initially 50. In this session, they mentioned that the Dmax 55 gray is possible. Ultimately, these patients undergone APR because reirradiation is now not routinely practicing here. After abdominal or perineal excision of the rectum, this patient's histopathology report was fine. This is the morality differentiated adenocarcinoma, and their DRM is uninvolved, CRM uninvolved, all are fine. This is PT2, N0, and MX. So patients on oral chemotherapy, tablet capecitabine, and regular follow-up. But after 10 months of this APR, this patient presented with perianal pain, and on DRE, actually on the perineal examination here, a harsh swelling felt on the perineal scar, serum C was normal, and again a MRI was done, and this MRI is showing the recurrence here. Probably I need help of radiologist here. Professor Vishwadit Bhumik, sir, can you just mention the pelvic recurrence here, which are free from this bladder or not, or prostate or seminal vesicle or any other organ involvement here, so that we can plan for the next surgery or radiation or something else?
Thank you. Here we are seeing actually two lesions contiguous with each other, and the upper lesion possibly invaded the posterior wall of the bladder. May I see more pictures? Do we have more pictures?
This is actually another picture.
Okay. Can you go to the midline?
Yes.
Yeah. So here, what we are seeing, it possibly invaded the bladder wall, the posterior wall of the bladder.
Do you think this is a free plane between the bladder and pelvis?
No.
Okay.
So there should be a fat plane in between them.
Okay, thank you, sir. So what is the report they given? That there is gross local recurrence at operative bed with marked regional extension. They say that it invaded posterior wall of the prostate and seminal vesicle, but this is abutting to the urinary bladder, but not clearly mentioned about the involvement, and some lateral muscle was involved, piriformis, pivococcygeus. So this is very difficult now, and a PET scan was done where SUV was found in the pelvic cavity. This SUV was used about 15.2 standardized uptake value here, but good sign is that there is no distant metastasis other than the rectum. This is the final picture of this condition now. This is the real scenario. This is the recurrence rectal canceration. So how can we proceed now? Can oncologist can break this barrier, or a surgeon can break this barrier with their tools, or we need help of both? First of all, comment from the Dr. Alauddin Maruri, what should be done at this stage?
So what is the prognosis now? I think the patient is incurable.
Yes, but one thing I should mention, that the patient echoes condition is fine, is equals 1, that is good for
his cancer is, so locally advanced T4. I don't think he is curable.
Okay.
I mean, okay, maybe you're going to talk about pelvic accentration. I don't know, you'll accentrate prostate and seminal cord. So to me, I think he is incurable. Now, maybe I can offer him some palliative chemotherapy.
Palliative chemotherapy. So this patient had no distant metastasis, only the local recurrence with good performance
but actually
status.
why I said palliative, because when this tumor is going to grow, it's going to fungate and give him symptoms.
So why not palliative radiotherapy actually? Because we are more concerned with the local side.
Radiotherapy, so you're not going to achieve much.
So you are going to prepare?
No, I think he got enough surgery, he got enough radiotherapy, and sometimes if we cannot really promise more than what we can deliver, then let's tell him, okay, look, right now the maximum we can do is some palliative.
Okay, thank
chemotherapy.
you, Dr. Gunath. Make a short comment about.
If patient is willing, so I will come some genetic assessment like KRAS and other factors also, other P53 and HER2 level. So that's also possible if there's wild type KRAS and HER2 positive, then I can try with that target treatment.
Okay, this patient had not yet any distant metastasis that the NCCN says about the indication of KRAS, BRAF or another therapy where the metastatic disease. So that's why this patient has not done any KRAS, BRAF. So Dr. Eliseo Morganti, we were very much curious about your important comment here.
It's difficult.
Mike, please.
Disciplinary team. So we should be here, the radiation oncologist, the radiologist, and the surgeon. And the question is, if I perform radiotherapy, if I re-irradiate, and I reduce the dimension of this tumor, are you able later to resect it or not? This is the question. Because if there is a possibility to go for abdominal perineal resection, we discuss together, all together. You tell me I'm going to resect here, here, here. My resection margin will be this. Together with the radiologist, we define together, not only me, we define together the target of radiation therapy. And if you tell me that there is one possibility to resect the patient, I will try to do it. Generally, you show us some program of radiotherapy in radiation.
Yes.
And I absolutely prefer accelerated hyperfractionation.
Accelerated hyperfractionation.
Why? Because hyperfractionation is able to reduce the risk of toxicity, and accelerated improves the efficacy of radiotherapy. Because rectal cancers are rapidly growing. So a fast radiotherapy, 45 gray, only 3 weeks, is generally very effective.
Thank you, sir. Now, Professor Dr. Jayed Khan, sir, please.
I would not completely rule out further local regional treatment for this patient, and obviously this is where the MDT should come into play, that we need to understand is further surgery, even in the form of an exudative surgery. I mean, this is S4, no involvement of bladder, possibly, or not, no involvement of bladder.
Yes.
I mean, we could do cystoscopy, we can assess those things, but S4 is not, I mean, people can go up to S1, S2 and exudative surgery. So I think we should look at the possibility of surgery, and if possible, as Professor Morganti suggested, some further radiotherapy. I mean, we could say it's questionable benefit, patient already had long course, but this is, what's the interval now from the initial presentation again?
Yes.
So this is a long time, and the patient had not had a distant relapse. So
Yes.
we really need to focus on further local regional treatment with some possible radiotherapy and possibility of exudative surgery for a fit and motivated patient. I do not see any role of systemic treatment here yet.
So it is time to Professor Shahadul Sheikh. Sir, before that, your comment, one question another. If we go for go like the Eliseo Morganti sir, that the re-irradiation here, which is not get earlier, and after re-irradiation, if this lesion become quite resectable, like the prostatic urethra is free. So previously you told about the resection should be including the previous margin. Now, if prostatic urethra is free after radiotherapy here, then if you consider the quality of the life of the patient with 2 diversion like urinary and fecal diversion, and if you consider the oncological clearance again after re-irradiation when prostatic urethra is free, so what will be your surgical choice now?
I think it needs discussion with the patient, how he convinced. Because ideal surgery for this patient right now, the probably re-radiation and re-evaluation for the local regional content. I mean, the with the urologist and the pelvic exenteration may be a good option. But still, I doubt after radiation artery resection whether it will be possible or not.
Before I go to the further slide, is there any comment from the audience? Any question or comment here? Many of the seniors are here. Professor Mausud Karim sir, Professor Mahmoud Rahman Romeo, and from the surgeon side, and oncologist here, Professor. Thank you. Anyone? Is there any question from the any resident or?
But I think with this scenario, I do prefer exenteration, posterior exenteration prefer if the patient is convinced. As it is, it can be excisable. If the patient is convinced, then we can first offer the patient for exenteration in the form of posterior exenteration. If he denied, then we can go for re-radiations. Because after radiations, if that disease come back or not respond well, then the surgery will be more difficult. Thank you.
So if we sum up the case, this patient initially an ultra-low anterior resection was done considering the post-TNT lower limit. So could we do a APR at this stage, and could we avoid? Yes.
Can I ask simple questions? When the patient was underwent surgery, first time surgery in the form ultra low,
Yes.
did they get the help after surgery? Did they get the frozen sections?
No, no frozen
Is there-
section at all. That's
is
a
there
good
any
question.
record
I
of
think.
frozen section?
Yes, there's the good indication of the frozen
But
section. at that
central
time.
like robotic surgery.
Yes.
Why
no,
not?
no, no. They have facilities, but they did not actually.
Again, the report, post-op report, surgical report was not available.
That's why I'm just some of the cases.
A bit surprising.
Okay, thank you. So this patient had an ultra-low anterior resection considering the lower margin in the 4 centimeter post-TNT state. Could we do an APR and if we could APR at that time, could we prevent it? That's a question. Okay, this patient had undergone a ultra-low, but probably a positive DRM may be found at that time because the histopathology's report was not supplied. If positive DRM was found, and if we could go for an immediate APR at that time, so could we avoid recurrence by this? That is another question. And after first year, the recurrence appear after APR. If we go for the re-irradiation at that time, could we avoid the re-recurrence? This is another question. These are the question. The answer might be it possible or it may not be, but we could take a chance by this way and we could prevent the recurrence actually. Because it is very difficult to treat the recurrence and break the barriers as we discussed by all of the panelists. So primary focus and the final message is primary focus should be on the preventing of the rectal recurrence rather than the treating it. Thanks to the panelists and special thanks to our delegates, foreign delegates present here. And lastly, thanks to the audience for their lively participation. And if any concluding remark from Professor Shahadat Hossain Sheikh, he can conclude here. Thank you all.
Thank you. Thank you for your wonderful presentation. Only one point I could differ, probably that Alicio told about the re-irradiation after initial local recurrence. But I think if the judgment is like that, arterial resection is possible, I personally, in my opinion, probably I will not prefer the re-irradiation where the arterial resection is easily possible. And of course, after DRM is positive, this patient is good option as APR immediately. Thank you.
Thank you, sir. Thank you all.
and evolving therapeutic paradigms. Today, we converge not just to discuss HCC, but we define its management through global expertise. To lead this high-impact session with wisdom and vision, I now invite our esteemed chairperson to kindly grace the stage, Professor Dr. A.M.M. Shariful Alam, General Secretary, Oncology Club, Head of the Department Clinical Oncology, Hassania Mission Cancer and General Hospital, and Brigadier General Professor Dr. Mohammad Kudrete Ilahi, Senior Consultant Medical Oncology, Hassania Mission Cancer and General Hospital. Please join me in a resounding round of applause as they take their positions. Now to begin this session with precision and intellectual rigor, I invite our moderator, Dr. Mohammad Saiful Alam, radiation oncologist in ICRH, to join the chairpersons on stage. With the dais complete now, I respectfully hand over the proceedings to Dr. Mohammad Saiful Alam. Thank you.
Respected faculties and delegates, Assalamu alaikum and good evening. I am Dr. Saiful Alam, welcoming you all to the hepatocellular cancer session of BICC 2025. We are extremely privileged to host luminaries from USA, Japan, Singapore, and India. Everyone is pioneer in their domain, united by a shared mission to conquer hepatocellular cancer. So, without any further delay, I would like to invite Professor Dr. Ghassan K. Abu Alfa, Professor of Medicine, Weill Cornell Medical College, Memorial Sloan Kettering Cancer Care, New York, USA. He will talk on advances in the management of hepatocellular carcinoma from biology to bedside.
Thank you very much for the introduction. Congratulations for the BICC on an excellent conference. It's quite enlightening to see how much is going on over these days. Dear colleagues, it's a great honor and delight to really give you the advances in management of hepatocellular carcinoma from biology to bedside. And I have to start by saying it's really an awakening and rather a surprise that the medical oncologist will be the first speaker in an HCC case. Actually, in the past, we didn't even talk because we didn't have much to say. But nonetheless, it's really a delight to see how much we can contribute. And really all, as we just heard from our chair, is a joint effort and collaborative effort as a teamwork with the other experts. With this, I'll just present my disclosures over here. And also, these are my contacts. And please feel free to connect with me at any time. My contacts are readily available through the BICC, but at the same time, if you'd like to take a picture of the QR code, you'll connect with me. And as many of you know and have seen before, always happy to answer any clinical question, of course, any research question and education question, especially for all the young trainees and fellows and residents. So with this said, I'm going to jump on through a couple of components, and my colleagues will appreciate that I touch on the liver function, the target therapy for biopsies. We'll talk, of course, at length systemic therapy and radiology, but we'll go back to local advanced disease because, yes, medical oncologists can have a role there. And lastly, we'll question access to therapy. That's an important component of where do we serve the world in regard to those new advanced therapies. In regard to liver function, please remember one thing. The Child-Pugh scoring that we really depend on was not really destined or intended for the evaluation of the liver functionality in liver cancer. It was a study back in 1973 by Dr. Pugh, or Sir Pugh, because he's Mr. Pugh because he was a surgeon in England. The idea was who is at risk for varices that can bleed. All of them were actually had cirrhosis, but none of them had HCC. Why did we settle to this? Because frankly, we did not agree to anything else. So just let's make sure that we take off any voodoo in regard to why we're doing the Child-Pugh, but let's live with it because all our clinical trials are based on the Child-Pugh, and we are really destined to look into this. No need to go over the details, but please remember there's a sequence of events in regard to how this occurs. Albumin followed by bilirubin, ascites, which is a clinical ascites, encephalopathy, which is a clinical encephalopathy, and PTINR. It's not like a flavor, I have this or I have that. It's really that sequence that really expect in that regard. And more importantly, the sequence lead to an exponential curve. This is not a linear curve. Patients live on a Child-Pugh A from DECA around the world back to DECA, and they're still Child-Pugh A, and then they curve into B, and then they shoot into C. And our job, of course, to keep patients at B, at A as much as we can, so we can serve them best. Now, if you ask me, is this really the best option to really treat liver cancer and assess liver cancer? Probably not. I would give credit here for Dr. Johnson in regard to the ALBI scoring, which really is rather more complex to look because you probably at least have some instrumentation, but they are available for us as apps. And at least I recommend for the clinical trial coming forward, make sure beside the chart you have the ALBI score. So hopefully with this joint effort that we all do, we'll hopefully be transitioning all of us to the ALBI scoring, which is more detailed and probably more accurate in regard to the assessing whole liver function. Now, with this said, the other point I would like to touch on before I deal to the meat of the matter is the target therapy and biopsies. And this is a big subject that comes along at many conferences right and left. And let me take a little bit back in history. When Jordi Bruges, back in the BCLC in Barcelona, brought in the idea that, you know what, if we're screening patients for potential liver cancer, we can look at the liver and we can see if this little lesion or that little nodule is probably disease or not, we can save ourselves a lot of biopsies. And we took it as a granted that we can just look at diagnose HCC by looking at imaging. Then carried on, Claude Serlin from UCSD and his group built in what's called the LIRAD system, which is like radiology for liver cancer. And if anything, they really have assessed that they found a correlation between certain descriptors in regard to the tumor, that how it looks on the imaging, and they will be say, okay, this is liver cancer or not liver cancer. Very important to remember that about close to 85% of the tumors that are local or locally advanced only, yes, probably it's reliable in 80 up to 85% of the cases. But when it comes to systemic therapy and systemic disease, it has never been tested. And here I like to quote three sentences Dr. Serlin brought in at the ILCA back in September of 2022 in Madrid, where he said, we do not have the data for evaluating the and applying LIRAD in regard to advanced HCC. So please, 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 if you really want to treat somebody with systemic therapy, you need to do a biopsy. And you will be amazed how many times you'll be wrong in regard that this is not HCC. If it comes to a surgical resection, I totally understand. This is really where entrusted surgeons, they know better, and they will definitely be able to apply it without any intervention. In regard to local therapy, yes, as well. But when it comes to systemic therapy, you need the biopsy as well. Now, I really don't know much about really the legal system in Bangladesh or in many parts of the world, but I'm not aware why or surprised why Dr. Serlin, when he was talking, said medical legal concerns are in my subconscious only. And I was wondering, why did he broke it up? So I went ahead, and it just happened that I'm a lawyer as well, so I just searched the medical system and legal system in the US, and in 2022 alone, there were 2 cases that went in court because it was misdiagnosed. And what was the diagnosis? As many of you have guessed, it was cholangiocarcinoma. And as such, please don't want to go into that route. It's not how we think, all of us. We don't operate that way. But definitely we don't want but to make sure that we ensure a patient is really treated correctly. And lastly, he said something rather cynical. And he said, oh, can you tell me about target therapy in HCC? And I said, well, you have to probably ask us. Because if anything, this is some of the early effort that we did at Memorial Sloan Kettering in New York, where we looked at the genetic alteration in regard to HCC. Why we're not really able to delineate more than through 3 pathways that are a little bit crude, not really very specific, the WNET pathway, the P53, and at the same time, the other, we call it the other because we know more, is because we don't have that much tissue. The more tissue we have, the more we are able to delineate how to really be able to not only diagnose, confirm diagnosis, but at the same time be able to really see how we can address targeted therapy in the future. So, with those 2 points, I would like now to touch on systemic therapy. And I have to tell you, I've been doing the HCC for like 25 years. And I'll tell you, when I started, there was nothing we can offer. We used to call everybody and send them to our dear surgeons who are really in the front row over here. And nowadays, we really got an understanding better about the rather very angry immune environment if the liver cancer in the liver. Enough that we depend a lot on the immune cycle over here, and pretty much we depend specifically at point number 7, what we call anti-PD-1, anti-PD-L1. I always like to describe this to our patients because please do use this kind of descriptors for patients, or your imagination can take you in way better routes as well, is that T cells come to attack the cancer cell, same as T cells will attack any virus, any bacteria, but there's a certain agreement that come upon between the cancer cell and the T cells, enough that it will offer a chair, the cancer cell, to those T cells, have a seat, don't touch us, we will not bug you. And this is exactly how we're protected by this chair called PD-1. And what do we do when we give anti-PD-1 immunotherapy? We simply kick that chair out, so as such, those T cells will drop onto the cancer cells. However, we all learned, and I can guarantee you, all of you, wherever you work, at whatever institution, whatever hospital, if you want to change any chair or any desk in your office, you have to call the boss. And the same thing in the immune system, there are bosses. And if anything, at point number 5, you see it halfway at 3 o'clock, this is where the anti-VEGF come to play. Think about the anti-VEGF as being like a mid-level manager. This is a person who really routes around the floor, make sure everybody's doing the right thing in the factory, and we need to make sure they are there all the time. But interestingly, you also have a CEO in every company, and this is at point number 3, which is CTLA-4, where really actually it happened in the lymph node, where, as we know, if the CEO send one letter saying do this or kick that chair out, guess what? They'll send only one letter. And this really was important. It's given only once. So let's dissect a little bit of these. What do they mean in regard to therapy? And I'll start by the one which really has been most commonly used, and I assume to be the only standard of care, simply because they were the first into the intervention, the AMBRAVE 150, looking into atezolizumab plus bevacizumab. Survival ultimately translated to about 19 months for the combination, compared to about 13 months for the sorafenib. 2 important points over here. The first one, please, this is more important as a safety message. If you decide to do atezolizumab, bevacizumab, make sure you scope the patients. Because with the anti-angiogenic, the anti-VEGF, people can bleed. And guess what? They can bleed to death. And if anything, make sure you scope them. Don't ever take it lightly. Oh, that's not bad patient, because you know where bad things happen when you don't want them to happen. So please always scope the patient. Now, however, that 19 month, let's hold on a little bit of thought for a second, because we're going to show the other data, and I will urge you how to analyze this comparator work. This is a Himalaya study. We probably led this from Memorial Sloan Kettering all over the world. This is the largest study ever done in liver cancer, 1,200 patients. And we looked at combination of 2 immunotherapies, anti-PD-L1, you remember the chair kicking out, and anti-CTLA-4, the boss telling the chair out. The mean survival was 16.43 months compared to 13 for sorafenib. And of course, all of you are already posing, say, well, wait a minute, you are trying to tell us that this 16 months is better than 19. 19 is a higher number. You're right, but hold your thought over here for a sec, because I can also take it the other way around. With the CARES 310 study that came from China that looked into camrysumab plus rivoceranib, anti-VEGF plus anti-PD-1, guess what? Mean survival 22 months, even better than 19 of the AMBRAVE 150. What's happening here? Interestingly, a nice retrospective study was done by our colleagues in University College London, and they looked at what's called the AB real study. A stands for atezolizumab, B bevacizumab, real world data study. And they found that actually the mean survival for the atezolizumab, bevacizumab is not 19, it's 15 months. Was somebody wrong here? Like, did they do something? Not really. But all depends, and this is really always the message, ask who are the patients of those studies. Because all what I can tell you is that in the ABL study, close to 30% of patients were Hep B, while in the AMBRAVE 150 itself, 50% of the patients were Hep B. And interestingly, Dr. David Pfister brought us to the Nature paper from 2021, you might recall that, where actually it was shown that when you have a more presence of Hep B, the checkpointers will work better. Why is that? There is a certain component of CD8s that will be enticed by the Hep B infection that will really lead to an improvement. And as such, you can see with the AMBRAVE 150, with, as you see all the way at the bottom, 50% of the patient were Hep B. If you go to the Himalaya, halfway, 30% were Hep B, And if you go to the KIRS 310, you see it right in the middle, 75% will Hep B. So altogether, we can think of whenever we have more Hep B, survival goes up. Less Hep B, survival go down. Well, great, we fixed it. Well, not really. Hold your thought. So if anything, interestingly, then a kind of like came to us from the left field, the checkmate NIDW, looking into ipilimumab plus nivolumab, which again, 2 checkpoint inhibitors, same thing, anti-CTLA-4 plus anti-PD-1, and it showed versus sorafenib lenvatinib a survival which is impressively close to about 24 months. But at the same time, we see that there are only 30% of people who are Hep B. So what's going on over here? Clearly, we discover there are more variables than we can think of that really can contribute to that part. And we have shown that already ourselves in our first phase 2 study that led to the Himalaya study, as you can see over here, with a higher CD8 cell population, low CD4 cell population, which really can add on to that exhausted CD8 cells. We found that actually there's a third variable, which is TOX, T-O-X, which you can see here kind of like inflicting into the tumor. And this, by the way, what led to the Nobel Prize this year with the FOXP3 as a regulator. So we don't think anymore it's only one variable or two. We think about it as being like more a combination of variables. And this is what we're working at the moment. We actually have great effort happening all over the world. We have cohorts of patients from Korea. We have cohorts of patients from India. We have cohorts of patients from the Pacific, because the Pacific has a lot of liver cancer. We have cohorts from Canada, from France, and from New York City. And we are really trying to understand better who would respond to a therapy. So we really jump on to that percent chance statistics to really, you'll get that therapy because this is your makeup of the tumor environment. And that's really what really led us ultimately to an incredible improvement in survival. As we can see over here, proudly, this is only first time that we see 5-year survival data on HCC in liver cancer. Admittedly, I've never seen that before. Actually, I should update that slide. I just came already from Berlin last week, and we reported 6-year survival data. We have close to about 18% or about 20% of the patients alive at 5 years. Numbers we were never heard of in regard to liver cancer, in regard to advanced and systemic therapy. With this said, I stop here and happy to answer any questions as per the chairs. Thank you very much.
Thank you, sir, for your excellent speech. Now, I would like to invite Dr. Makishima Hirokazu. Dr. Makishima is the Chief Physician of National Institute of Quantum Science and Technology, and he will talk on evolving role of radiotherapy in hepatocellular carcinoma from evidence to practice.
Thank you for the kind introduction. So today I'll talk. Well, yesterday I talked as purely as a radiation oncologist. Today I'll talk about a radiation oncologist also being a hepatologist also. So these are my COIs. Okay, so HCC is a quite common disease here in, well, in mostly in East and Southeast Asia. This is generally overlaps with the occurrence of HB, but that is subject to change because of all the antiviral drugs and the emerging of MASH-MASLD. So we all know about the risk factors, so I'll just skim through, but so we are seeing less Hep B, Hep C related HCCs, and now more increasing MASH derived HCCs. So I'll just so the thing is that in the NCCN treatment guidelines for HCCs, there is minimal mention of radiotherapy. This is also so in the BCLC guidelines, and yes, it has been updated, I think it was 3 days ago or 4 days ago, yeah. But yes, it still lacks the mention of radiotherapy. It has, if you read into the actual article itself, it does mention about radiotherapy, SBRT, and a little bit about protons, but there is no mention in the flowchart itself. So, well, it's just minimal. Okay, so, but actually there's a lot, if you've been treating HCCs, there's a lot of gaps within these flowcharts. Yes, it has been described very, very detailed, but there are gaps between these lines. So let me present you a little case. 85-year-old female, hepatitis B, under NA, with a Child-Pugh score of 5A. Primary, solitary, 2.5 centimeters, no MBIs, and a modest elevation of AFP of 40 nanogram per milliliters. What would your first choice be? Let me present you another case. A 65-year-old male with MASH LC, Child-Pugh score 6A with a modified LB score of 2B. Primary, solitary, 7 centimeters in diameter, S8, partly S5, S7. No MBIs, and again, a modest elevation of a P of 150. What would your selection be? Okay, so the issues with the current guidelines is, well, extensively categorized. Gaps in the system are significant. American and European guidelines lean towards transplantation where it may not be feasible in Asia, and minimal description regarding radiotherapy. So the most survival affecting factor, apart from tumor control, is the liver function, and, well, the remnant liver function. HCC is a recurring disease. Liver cirrhosis itself is a strong risk factor of HCC. So it is essential to treat and manage HCCs without affecting liver function, or the function reserve. And balance between tumor control and liver function is always the million-dollar question. So we have a couple of local regional therapy options. Of course, well, surgery being the golden standard, but other than that will be RFA MWA, which has a very good local control, which emerged in the 1990s, and good liver function preservation and repeated treatment is possible, but is limited by size, and biliary toxicities will be an issue. TAE, TACE, ability to treat multiple lesions, very nice, but the issue is with the low tumor control rate and the liver toxicities. So if you repeat TACE, you will, the patient will suffer from low liver function. That's where radiotherapy comes in, SBRT and particle therapy. Actually, particle therapy for HCCs came before SBRT as the definitive radiotherapy option for HCCs. In the 1980s, a team from Japan wanted to treat HCCs with radiotherapy and came up with proton therapy. So good local control and ability to treat larger tumors, yes, and repeated treatment is also possible. But it does come with a high cost. Whereas with the SBRT, well, moderate cost and good local control, but limited by size. Anything over 5 centimeters could be very challenging. Liver function toxicities also lead to limited repeated treatment. So radiotherapy 101, effect and toxicity only occurs when it has been irradiated, and effect and toxicity is dependent on the absorbed dose. So this is a figure I like to use. This is obviously a head and neck case with dermatitis, and you can, when the dose is superimposed, the high dose area will correspond to the severe dermatitis, whereas the low dose, not as much. So SBRT, high dose per fraction, higher efficacy, higher toxicities. So in most cases, when dose per fraction goes up, toxicity worsens before efficacy improves. So SBRT can only be realized with good patient positioning and internal motion addressing. So the key factors in radiotherapy for ACCs are large and complex internal motion due to respiration, OARs, especially the GI tract, and the target being within a very low tolerance dose parallel organ, which is the liver itself. And you have to consider repeated treatment. So with SBRT, while lacking level 1 evidence, real-world data shows significant improvement over TACE and possibly RFA also. Definitely a viable option when surgery nor RFA MW ablation is not an option. And the literature says 3 to 5% radiation-induced liver damage. And but this, I'm quite skeptical about that. And most of the literature do not distinguish between classical RILD and non-classical RILD. Classical RILD is the actual, the one you can't save. And the non-classical RILD is, well, that's just radiation hepatitis. So long story short, your plan sucked. So the actual toxicity itself is probably a little bit more mild. Okay, so back to the case, first case. So this one, not such a good candidate for ablative therapy because of the proximity to the bile duct. Surgery, if you want to resect this 85-year-old female, yeah, well, knock yourself out, but yeah, maybe not the best option. So in cases like this, well, SBRT is a good option. So re-irradiation, you will have to do re-irradiation to the liver. Not necessarily to the same tumor, but a recurring new lesion. So can re-irradiation be an option? So the issues here will be, can the liver tolerate another course of radiotherapy? Or can the OARs, other than the liver, tolerate another course of radiotherapy? So sadly, we don't have any prospective studies regarding this. There are a few retrospective studies implying safe treatment. They show same local control, same liver toxicity, and spared liver volume MLD B20 didn't show to be a risk factor of overall survival. The caveat of this study was the small tumor size with median diameter of just under 2 centimeters. So large and complex internal motion, well, is addressed. OAR, especially the GI tract, can be also addressed. Target within a low tolerance dose parallel organ can be an issue, especially in large and/or centrally located tumors. And repeated treatment could be an issue. And that is where particle therapy comes in. So when we're talking about particle therapy, we're talking about carbon ions and hydrogen ions. So what's so special about, well, not just carbon ion, but particle therapy in general, is that we have the Bragg peak, which enables us to produce a distinguished dose distribution. Now, the higher biological effect of carbon ion is not so relevant when we're talking about HCCs. So it's just pure dose distribution. So with SBRT, you can see the, well, 50% isodose line here, whereas with particle therapy, it's very confined to the tumor, and also the 30% line also. So you get like about 40% to 50% decrease in the, especially the 20 gray to 30 gray area, which actually means the most. Okay, the only issue with particle therapy is the huge size. This is a carbon ion, this is the carbon ion accelerator we have in my facility, QSD. It's 60 meters by 120 meters, so yeah, about 2 tennis courts. Proton machine also a little bit smaller, because the diameter here is about 13 meters, but so a little bit smaller, but still very large. The treatment room, and yes, of course, respiratory motion management is also a very key factor of this technology. So, how are the outcomes? So, particle therapy, comparable with SBRT in smaller tumors, and better than SBRT in larger tumors. We actually did a meta-analysis and comparing SBRT and particle therapy. I'm really sorry I cannot show you the actual figures because it has not been accepted yet, but it should be available within the next few months. Also, repeated treatment also being reported to be safe and great option for larger tumors, decompensated liver function, and tumors with MDIs. The toxicity minimal with up to 1% RILD and GI hemorrhage. So looking back at the second case, well treated with proton. This is passive protons, so you get a higher dose here, but still. So even like tumors like this can be treated with carbon ion, even with decompensated liver function. Okay, here's another case with a tumor here. I treated this like this, but this this dose distribution, this treatment plan has a critical flaw here, and it's the dose to the stomach. Had a very high dose to the stomach, about D2cc of 24 gray in 2 fractions. So after 1 month, we see this sort of redness here. Gets better at 3 months, but you can see a very narrow but very deep ulceration at 6 months. Now, if you see this with after any treatment, say cervical cancer treatment, you're expecting a huge ulceration. But with particle therapy, there's no dose around here, so it gets better. So I think, yeah, we're running out of time. Yeah. So, okay, so particle therapy for advanced HCCs and MDIs. So reported overall survival is 26 to 40 months. So ICI is reporting 8 to 10 months, so that's something quite substantial. Minimal toxicity, including hepatic function, but the low progression-free survival is an issue. So there are a lot of trials going on with radiotherapy plus ICIs. Also, reiteration for ACCs with particles can be done with second radiotherapy, same local control and same, well, no liver toxicity. So, yeah, I think we could just skip this. So, in summary, radiotherapy offers definitive treatment opportunities for those who are not eligible for resection or RFAMWA. Good efficacy over 90% local control in 3 years with limited toxicities, even for the clinically unfit. Conservation of unirradiated liver and keeping liver dose as low as reasonably possible is crucial. And re-irradiation is possible, though careful consideration to the liver dose is important. Particle therapy can well treat tumors over 5 centimeters where SBRT is not an option. So that's about it for me. Thank you.
Thank you, Dr. Makishima Hirokaju, for your excellent speech. Now I would like to invite Dr. Han Chong-to. He is a Deputy CEO and Senior Consultant, Medical Oncology Division, National Cancer Center, Singapore. He will talk on role of immunotherapy and targeted agent in hepatocellular carcinoma.
Thank you very much. You know, actually, Professor Gassan has already given my talk. So I will just give it a brief overview. And you know, it's a funny coincidence. I was just in San Francisco having dinner 3 nights ago with a radiation oncologist from UCSF who was trying to convince me that SBRT should be the way to go for local HCC. So it was very interesting to hear our friends talk from University of San Diego as well. I'm not sure what's happening. Okay. So this is me, and I'll just quickly, I know in the interest of time, I won't take too much time away from dinner. So, you know, this is a huge topic, so I'll just focus on a few things. The first thing to say is at the National Cancer Center in Singapore, my former boss, Professor Su, had actually initiated MDTs a long time ago. And this is the way we treat HCC in the National Cancer Center. And we have a group of people who are all in the same room. And to this day, as Professor Gassan will know, Professor Pierce Chow leads an MDT every Friday at NCCS as well. So we continue to treat HCC this way with multiple specialists here. But just very quickly, again, you've heard the talk by Professor Gassan that those of us who are old enough will remember the days when hepatologists would give doxorubicin, or sometimes we would have given FOLFOX, and I think in China they sometimes still do that. But really there wasn't a lot of treatment for HCC 25 years ago. And I think remarkably, the SHARP trial showed us in, I think, 2008, that there was a possibility of improving outcomes and survival in HCC. The REFLECT trial, which is a non-inferiority study with lenvatinib against sorafenib, showed that you can give a drug which is actually quite one of a favorite TKI of mine, better progression-free survival. BRAVE 150 you've heard already, and of course the COSMIC wasn't a positive study, but Himalaya, a trial that of course Professor Gassan was first author of in the New England paper. And later on, he also talks about the other studies, CheckMate 90W, which was just recently published, and CARES trial from China, and then Apollo as well from China. And then in locally advanced setting, you see 2 trials, EMERALD-1 and LEAP-0112. The EMERALD-1 did show a positive outcome with, unfortunately, with some toxicities. So I'm just going to very quickly show you what these things look like. So compared to 25 years ago, you have a lot of options and a lot of opportunities. And of course, immune checkpoint inhibitors lead the way in a first-line setting, and to some extent, a second-line setting as well. So here, of course, is in BRAVE 150, and this trial was actually presented at ESMO Asia in 2019 for the first time, and of course published with Richard Finn as a first author in New England in 2020. And this is where you see that just after Professor Cheng An Lee's presentation in Singapore, we took him out for lunch. And and Gassan will know these people. Stephen Chan is there, Xu Qin is there, Chu Sipin, and we took him out for lunch to celebrate the historical occasion in 2019, a strong positive survival and progression-free survival, response rates that were actually way better than sorafenib, and this is in a first-line setting. And here, of course, Professor Gassan's study in the Himalaya, published in 2022 in New England. Again, you see that long tail, and as he said, in Berlin, I think you have extended that long tail beyond 5 years. It's not a hard regimen to give. So it's Tremi-Durva in the first dose, and then after that, it's just Durva beyond that. The problem in Singapore is that this was an extremely costly regimen until it just got recently approved a couple of months ago, and in our cancer drug list. So it's a lot cheaper now than it used to be last year. Checkmate 90W, of course, was recently published also in the Lancet, and the first author is there, Thomas Yao, who's a friend of mine. And in Checkmate 90W, what you see is rather interesting, and I will ask Hassan this over dinner, is that why do you see an early dip of the Ipi-Nivo arm before you see a positive outcome? Is that because there are more deaths in the early setting of giving Ipi-Nivo than later? But as you see, with over the time, you can see the survival benefit continues to widen, and they do have very strong survival benefit. And here also there was a comment about how hepatitis B carrier patients were not that high in this group of people, and yet you saw a strong survival benefit. I think the issue of Hep B positive patients is still uncertain. I mean, in Singapore, 70% of all HCCs are Hep B positive. I believe this data is similar to Taiwan, Korea, and China as well. I know in Japan it's more Hep C. The question now is whether virally driven HCC has a better outcome to immune checkpoints. It's not clear, but there is a lot of interesting science behind it. So here you see all the positive data stacked up against each other. So with Embrace 150, it's 19 over months versus 13 over months. In a Himalaya, you see that data as well. Yes, it looks a little bit less, 16 point something versus 13 point something, but they have perhaps the only beyond 5-year survival data that's been reported. And again, Checkmate 90W, you see even better results, 23 versus 20. So what you see is that 20 months is quite unusual for sorafenib or lenvatinib. I think that's probably because there are better second line and even beyond second line treatments now for HCC, and the management of HCC has become so much better than before. So what about patients who have autoimmune disease? Can you give an immune checkpoint inhibitor in the context of patients with autoimmune disease? So from yellow to red, you see that, well, if there's only a family history or a bit of thyroiditis or thyroid disease, the answer is you can give it. It's all based on a risk-benefit analysis. But if you move all the way to the right side in red, if the patient has autoimmune neurological disease or had solid organ transplant, I think the answer is you try not to give immune checkpoint inhibitors for HCC because you then run the risk of running into severe problems. So this is where we can make a decision based on your own clinical judgment. And then what about bleeding? As Professor Gassan has said, you tend not to give patients with varices atezo-bev, and this is really in the context of atezo-bev. But there are people who can give, if it's banded already, you can actually consider atezo-bev if you believe that the risk is not high. But if you go all the way to the right side and you see ruptured HCC, which happened to a patient of mine 2 weeks ago, you try not to give atezo-bev again. And if you see very severe esophageal varices that's not banded, you wouldn't want to give atezo-bev as well. So these are some of the considerations with high risk of bleeding. Very quickly, of course, this was actually a slide by David Pinato from the UK, who presented this data at ESMO Asia last year. The very fact that you have varices at pre-treatment is not an absolute contraindication. We all watch this space very carefully. If you abandoned a patient and the varices wasn't very severe, I mean, we do sometimes consider giving atezo-bev, but now that you have STRIDE, you might consider separately, and now you have 90W, you might also consider that separately. Cardiovascular disease, if it's just a question of hypertension or past history of ischemic heart disease with no acute coronary syndrome, you may not worry about that. But when you have a severe stroke or congestive heart failure, don't even think about giving IO therapy or anti-angiogenic therapy as well. So real-world data, Child-Pugh B, which is a common problem. I think the data for both nivolumab as well as now atezo-bev suggests that you can give these drugs in a context of Child-Pugh B patient. In B7, you still see a response rate and you still see a survival improvement, but not as well as Child-Pugh A. So I'm just going to very quickly wrap it up with the first case. This is an 82-year-old patient I treated in 2018. He had a family history of multiple cancers. He had prostate cancer in 2007, surgery and RT given, Hep B carrier on entecavir, former smoker, social drinker. So on a surveillance PMSA scan for prostate cancer, they found lung nodules and a liver lesion, 1.8 cm. I'm sorry, my bad, 2.9 cm. Alpha fetoprotein was quite bland, and he had fatty liver. So he basically had a liver biopsy done in 2018, which confirmed HCC. He's 82 and he runs 10 kilometers a day. It's crazy. I don't run 10 kilometers a month. Then he was recruited into Embrace 150. He started treatment in 2018 December. This was the lesion, I believe it's 2.9 cm. This was where the liver biopsy was done to confirm HCC. And then, so we actually recruited him and he ended up on a Atezolbev. And if you can imagine, 2018 and 2019 was the beginning of COVID-19 pandemic. So you see, this is how we treated him. We were all sort of gowned up. And the clinical trial in Embrace 150 continued to proceed in spite of COVID-19. So here you see he had mild fatigue, he had no immune-related AE, he had some hypertension, which we had to give 2 drugs for, Atacant and amlodipine. His treatment-related hypertension got better. And in October 2020, he developed grade 3 proteinuria. Based on the trial protocol, he had to drop 2 doses of BEV. We saw an endocrinologist, or referred him to an endocrinologist. He was given Invokana, which is a diabetic drug to reduce proteinuria, and in fact it did, so we continued BEV as well. We told him to stop running before he has his urine test because we know running can increase proteinuria, and he carried on with his treatment all the way until the end of the treatment timeline. Just bear in mind that the presence of proteinuria is actually a positive prognostic factor for patients who are taking Atezolbev. So you see the lesion actually got smaller and the lung lesions went into near complete remission. Oh, I think my microphone died, sorry. Not sure what happened. So in 2024 and 2025, so this is what happened. So, if you remember, in 2018, he started treatment. So I just wanted to share with you that Roche said, well, he had such a great response. You can just keep giving Atezolbev free of charge. And I think at that time, nobody knew how long or what duration to give Atezolbev for. So in 2023, his lesion got a little bit bigger. His lung lesion remained stable. So can you imagine, by February 2024, he had 80 cycles of Atezolbev. So this was a guy who was 82 years old at 2018. So by 2024, so that's like 4. So he would have been more than 85 years old. We offered him RFA. And of course, when you give him RFA for that liver lesion, because the lung lesions all completely disappeared, he would be off trial. And he said, look, at first he didn't want to do it, but eventually we did give him RFA, I believe. And by June 2025, after the RFA, he still remains in complete remission, and I still see him every 6 months now. And remarkably, at 86 years old, he continues to run every day. So it's been quite amazing. It's quite an amazing story. It's an amazing story from the point of view that this is an older guy. He is hypertensive. And he was able to tolerate Atezolbev, and he went into complete remission. Of course, we had to give him RFA for the local lesion. But this was a really interesting and very gratifying case for all of us to treat HCC to treat. The case number 2, and this is my last case, so bear with me. So this is a case of a Singapore patient as well, a younger guy, 64, retired banker, non-smoker. So that's just a picture of the banking district in Singapore. He's MAFLD, MASH, Hep B positive, the usual hypertension, hyperlipidemia, etc. He was found to have poorly differentiated HCC, and then after resection. And then the AFPs started to rise from 13.2 to 63.3. And then you found a lot of lesions in his liver after that. He had no portal vein invasion, Charles-Pugh A5. He was given a lot of things. So we started with Atezolbev, and the alpha fetoprotein continues to rise. So I think if you see a rise in alpha-fetoprotein early on atezolizumab and other kinds of IO, you know it's bad news already. And he had profound fatigue. This was quite interesting for me to see. He had profound fatigue on atezolizumab. And fatigue has actually been reported as a poor prognostic marker of HCC. By 2023, we quickly switched him to Lenva at 8 milligrams. He's 64 kilos. But then in spite of like 1 or 2 months of Lenva, his disease still continued to progress. He was getting symptomatic from abdominal discomfort. So I have to qualify this in front of world leaders in HCC like Ghassan, is that we switched him to capecitabine and thalidomide because, you know, this guy is retired. He is not financially strong. And we actually published a paper more than 10 years ago in American Journal of Clinical Oncology using CAPE and thalidomide, bearing in mind that there was a multi-center trial with CAPE and bevacizumab in BJC. So the reason is this is actually very cost effective, and we do sometimes treat patients with CAPE thalidomide in this setting. Whoops. Later on, he was referred for Y90, he was too hypovascular for that. And then we started him on cabozantinib at a low dose. He was quite fatigued and quite symptomatic by then. And here you see, you know, what is amazing is that, and I don't know the answer to this, and I wish we had a biomarker to tell us, is that he responded to cabozantinib when he failed every other treatment. And if you all don't know, cabozantinib trial in the refractory setting for HCC, Ghassan was also the lead author of that New England paper. And, you know, it's, if I'm not wrong, it's an AXL, MET, and VEGF receptor 1 to 3 inhibitor. In fact, he did tolerate cabozantinib at low doses, and he remained well, but alas, with poorly differentiated HCC, he eventually demised. So my last slide is to talk about AFP. And really, in the setting of AFP, if you see a response by 6 weeks with AFP, you know you're in a good place. And even with the non-IO trials, a raised serum alpha-fetoprotein baseline is related to poor prognosis with TKIs as well. Just now we had a good education about all the ALBI scores and LIRAD score. And the CRAFTI score is really a combination of CRP and AFP as a biomarker of therapeutic response. And of course, Professor Ghassan talked a lot about bridging and downstaging, and that's really a talk all by itself, and curative conversion as well. But a lot of systemic therapies are now going into the intermediate state HCC setting. So with that, thank you very much.
Thank you, Professor Han, for your valuable speech. Now it's time for our final speaker, Dr. Nikhil Agrawal. Sir is a director of GI HPV Surgical Oncology, Max Super Speciality Hospital, New Delhi, India. Sir will talk about optimizing surgical candidacy for hepatocellular carcinoma in resource-limited settings.
Good evening, everyone, and probably I'm the only one who's keeping you away from the dinner. Thank you, previous speakers, for setting the context and enlightening us about newer molecules, newer particles. But unfortunately, many of our patients will not be able to afford these therapies. And very few of our patients will actually be surgical candidates. And I'll be talking about optimizing surgical candidacy for HCC, especially in resource-constrained settings. Right? So we know in Bangladesh, HBV is the leading cause of HCC, about half of the cases. And HBV prevalence has dropped in Bangladesh, and it is now 4% as per the recent data. Now, when we talk about resource-limited setting, what we are talking about is late presentation. We are talking about financial and logistic constraints, which affects people accessing healthcare. Diagnostic resources are limited, and as a natural history and late presentation, very few of them will be, actually a candidate for surgical resection. Obviously, loco-regional therapies, immunotherapy, and liver transplantation, they are very limited, right? And many of these patients will be financially constrained, they will not be able to afford treatment, and they will probably quit treatment at some point of time. A number of specialist HPB surgeons who will be treating these patients with surgery is also small. So these are the challenges which we are going to face. So obviously prevention is better than cure. Vaccination program, routine screening will pick up these lesions at an earlier stage where we can do something about them. And data clearly shows that if we do that, we will pick them up at an earlier stage and we will be able to cure them better. But having said that, if we see a patient with HCC, what do we do? So HCC is an interplay of three factors. Most of these patients will have chronic liver disease, they will have a bad liver, they will have disease, and we will have to see how the patient is doing. So we have to, balance the benefits of treating these patients with potential harms of treatment in view of their liver being bad. So we have to quantify tumor burden, we have to measure extent of liver dysfunction and see the performance status of these patients. Obviously, we have to do biomarkers. If we look at the Western guidelines, they are not very pro-surgery. They are more leaning towards systemic treatment, loco-regional treatment, and liver transplantation, while Asian guidelines are more permissive towards liver resections. This is a chart. This is a BCLC guidelines, which was updated just 3 days ago. And if we see, a very small fraction of these patients are going towards resection. On either side of it is ablation, transplantation, TACE, immunotherapy, and they have introduced a very important concept, that's CUSC. I do believe that BCLC underutilizes resection. It's too restrictive. It's okay with other therapies. Now, if we look at the data where people have done resection beyond BCLC, you will see we can get good outcome in well-selected patients even with resection. So here there are 4 series, and you can see BCLC-B, BCLC. When surgery is compared with other modalities, the survival outcome is good in surgery arm compared to the other thing. If we look at multifocal HCC, if we look at HCC with vascular invasion, also again in well-selected patients, outcomes are much better than non-surgical modalities. Another pressing concern is clinically significant portal hypertension. When we talk about clinically significant portal hypertension, it is defined by either HbPG more than 10 or varices or history of bleeding. Generally, liver resection is considered a contraindication in patients with CSPH. But if you look at the series where well-compensated cirrhotic patients were operated, they did well. And if they were operated with a minimally invasive approach, they did very well, right? And when we look at the 5-year survival and recurrence-free survival of these patients, that's almost 55%. That's kind of unheard of with any loco-regional or systemic treatment. So the point here I'm trying to make is that surgery should not be thrown out the window. Surgery is a very good modality for treating these patients if we select our patients well, right? I can show you example of a case. This is a 60-year-old gentleman. He had HCC with clinically significant portal hypertension, grade 2 esophageal varices, but otherwise he had good performance status. His child score was good, and we decided to do a right hepatectomy, and he did well. He's still doing well. This is around 6-7 years, right? So when we talk about resection for hepatocellular carcinoma, it is not the only one. We also have transplant, but it is a modality with curative potential. It should be at least thought of as a first-line treatment in patients with preserved liver function and preserved functional status. It's obviously would be cost-effective in a constrained resource setting, and it will give us tumor for histological and molecular analysis. We can do repeat resection or ablation later on, and it can sometimes be used as a bridge for liver transplant. But obviously, at the same time, we are worried, some of these patients might decompensate in the postoperative period. They can have post-hepatectomy liver failure, recurrence rates are high, and guidelines, as I said, typically restrict it to very selected patients. So we have to choose very wisely, yes? Very wisely. So when we look at selecting patients for resection, it's, as I said, interplay of 3 important concepts. That's one, patient. How is our patient doing? His PS0, PS1. How is his liver function, whether there is portal hypertension, and if we are going to operate these patients, how much functioning liver is going to remain there after the surgery. And then we have to look at the tumor. There should not be any extrahepatic disease. The tumor has to be resectable with a functioning liver parenchyma, which is going to remain. And biology we have to look at. We have to look at AFP, we have to look at PIVCA. Now, if everything align, we have a good liver, we have a good patient, and a tumor biology is good, then only we are talking about resection. And if these criteria are met, then we should not shy away from resecting these patients, even in contrast to what guidelines recommend. And obviously we have to use a MDT. So when we look at the patient, we look at the age, we look at performance status, we look at extrahepatic disease, we look at comorbid illness, we optimize them, we improve their nutrition, we look at their liver function, and we all know child PUG score, we know MELD score. LB score has been shown to be very good. Previous speakers has already alluded to that. And if your center has the facility of doing ICG retention at 15 minutes, that's a very good test. That is very good predictive marker. Then we can look at portal hypertension, we can do an endoscopy, there can be varices, splenomegaly, platelet count, collaterals on imaging are indirect markers. HVPG is not available in every center. If you have, fine, measure HVPG. Otherwise, you can do a non-invasive assessment. So this is a score which you can use. This is called as pH score. Cutoff is 4, and you can just calculate these parameters, and it has been shown to be as good as HVPG. So you look at portal hypertension and other parameters as I mentioned, and then you look at future liver remnant. So if you are going to do a right hepatectomy or left hepatectomy or right segmentectomy, you have to see how much liver is going to remain after that, right? Because as I said, PHLF is the most concerning thing in these patients, and when it occurs, it leads to mortality. So we want to avoid that. So we have to do a volumetry, we have to look at FLR, and this is how we do a CT volumetry, and these are the numbers which we want. In a normal liver, 20%, in a cirrhotic liver, more than 40% should be there if you are planning for a liver resection. Sometimes FLR is not adequate, then you can use some strategies to increase FLR. The most commonly used is portal vein embolization, and ALPS is generally not used in HCC, and we can do non-anatomical parenchyma sparing resections, though they are considered a little inferior to the anatomical resections, but yes, if FLR is not adequate, we can resort to that. And this is one of the examples where you can see pre-PV and post-PV scans. When we look at technical considerations, when the tumor is resectable or not, we have to look at biology, we have to look at tumor markers, we have to look at the distribution of the lesions in the liver. They are unilobar, they are bilobar, they are generally we will not operate bilobar lesions, and up to 3 are preferred if we are planning for surgery, not more than that. If there is any vascular invasion, micro or macro, and any extrahepatic disease. The good patients are solitary tumors, no major vascular invasion, up to 3 nodules, and more than, even larger tumors can be operated if rest of the criteria are met. Right? But we should also be beware of the high risk features and generally should avoid operating in those patients, and they are patients with portal hypertension, but selected patients can be operated as I showed you, increased bilirubin, low albumin, elevated INR, elderly patients, comorbidities, HBV DNA which is very high, and AFP which is very high. These are poor biological markers. Obviously we have to optimize these patients with nutrition, optimize their smoking, alcohol if there is anything, and if they are having any viral hepatitis, we have to treat for that. Right? So once we have optimized that, we have taken them up for surgery, then we have to look at principles of resection. We have to have good margin, preferably more than 1 centimeter, but if it is also small, in the interest of preserving more parenchyma, we can do that. Obviously, we have to use a low CVP anesthesia during surgery. We can use selectively Pingle. We should prefer inflow occlusion. And when it comes to parenchyma transaction, different surgeons have different preferences. We prefer CUSA. Some surgeons use harmonic scalpel. But a clamp crush technique is equally effective. And especially in a low resource setting, it should be adopted. Right? And I would want to specifically talk about minimally invasive resections, because if you look at data, this is an approach which has actually been shown to improve outcome in these patients. The routine minimally invasive advantages, that less blood loss, less transfusion, early discharge, those are there. But what is most important or what is most charming for me is that these patients, when undergo a laparoscopic procedure or a robotic procedure, minimally invasive procedure, I will not talk about robotics here in the interest of low resource setting, but laparoscopic is as good as robotic, and they do not have much impact on their liver function post-operatively, right? So if possible, we should try and develop skills and we should operate them laparoscopically. I will just show you an example video of a cirrhotic patient with portal hypertension who had a large lesion in, I will just go a little fast. You have to do an intraoperative ultrasound. We detected one more lesion in segment 6, and then we did a left lateral. And a segment 6 lesion, non-anatomical resection. This was an HCC, and the segment 6 was a regenerative nodule. So this is standard left lateral. And this is the left hepatic vein, and then and this is a segment 6 lesion here. So we can drop it here. And when we talk about the post-operative management, it's a routine post-operative management with special emphasis on post-hepatectomy liver failure prevention. So nutrition has to be maintained. We have to keep them well hydrated, and we have to manage complications. But what prevents is that a good surgery. So there has to be minimal blood loss. There has to be operative time has to be well under control. And obviously we have to choose these patients well. And if you have the facility of ICG, it has to be done, and FLR is very important. We can also deploy ERAS protocol in these patients, and it has been shown to improve outcomes. If we look at the results of surgical series in well-selected patient, we can see a 5-year survival of 50 to 70%. Recurrence rate is high, but still it results in meaningful high 5-year survival. In experienced centers, high volume centers, mortality risk is very low, close to 2-3%. Morbidity rates are on the higher range, almost as a Whipple, almost 30%. And early stage solitary tumor, no vascular invasive, R0 resection, good liver function, no portal hypertension, antiviral therapy has been shown to improve outcome in these patients. A few slides about transplant, because obviously there are 2-3 issues in transplant when it comes to HCC, especially in our setting. Most of us don't have a well-structured DDLT program. It's an LDLT program. Availability is a concern, then cirrhosis, liver dysfunction, cost, and long-term outcome. So everything has to be put together, and then a holistic approach we can see. But if possible, transplant is a good choice for HCC, and it can be done. And I think we can skip. So take-home message is that resection should be done if it can safely be done. And it is one of the curative options, including hepatic transplantation and ablation. Patient, liver and tumor, these are the key considerations. We have to have a very focused approach on all these things, and minimal invasive surgery improves outcomes. Thank you very much.
Thank you, sir, for your dynamic presentation. Now, I would humbly request our chairperson, Professor Brigadier General Dr. M.D. Kudrat-e Ilahi sir, to make his valuable comments regarding the presentations.
Dear audience, Assalamu alaikum. Today we have learned 4 speeches, which is very valuable. Regarding liver, we know liver is an organ that can regenerate tremendously, but when it is affected by cancer, the prognosis is dismal. How it is dismal? If it is a cirrhosis, then overall survival may be more than 12 years. If ACC is there, BCLC criteria A, overall survival may be 5 to 8 years. If it is BCLC-B, overall survival 2.5 to 4 years. And if it is C, 1.5 to 2 years. If it is D, less than 6 months. So it is very important that before development of ACC, we should protect the case. Especially in case of cirrhosis of liver, we should go for regular screening and early detection. Now, about the first speaker, Dr. Ghassan, he has told about biology and molecular insights. What is my take from here? We should go for core biopsy for liver cancer because it is important for molecular study and further treatment, personalized treatment, targeted therapy, and further preparation and reassessment. So core biopsy will be an important issue. Though we know that if AFP is more than 600 may be considered as HCC, but nowadays in the era of precision medicine, we should go for core biopsy. Next speaker was Dr. Hirokangju, evolving role of radiotherapy in hepatocellular carcinoma. It was an evidence-based practice. Nowadays, it was our thought that radiotherapy is a palliative setting treatment, but now it is incoming as an integral component of therapy. So what are not only that, we have also learned from his speech that re-radiation after radiation can be also effective up to 90%. And what are the methods? He has told about SBRT, proton therapy, IGRT. Another some evidence is that bridging for downstaging for before preparation of transplantation, there are trials going on. And combination therapy may be also given, radiotherapy along with TACE and systemic therapy. Next speaker, Dr. Toh, role of immunotherapy and targeted agents in hepatocellular carcinoma. All of you know it is the treatment for advanced stage hepatocellular carcinoma. He has mentioned about I Am Brave, Himalaya, Checkmate 9DW, and other trials. But in our country, we are using I Am Brave, this trial, atezolizumab and bevacizumab. Result is very good comparing to our other systemic therapies. Another next speaker, Dr. Nikhil, optimizing surgical candidacy for hepatocellular carcinoma in resource-limited setting. We know in our country, liver surgery is not very available in our country. So it is very important because if we diagnose the case in early stage, the only treatment is resection or transplantation. We are lacking of this. Inshallah, we will get surgeons in our future days. Thank you very much for patience hearing.
Thank you, sir, for your valuable remarks. Now, I would humbly request our chairperson, Professor Dr. A.M.M. Shariful Alam, sir, to put his valuable remarks on today's presentation.
Thank you, Dr. Saiful. We are in a decimal position that the management of HCC throughout the whole world is a controversial issue. And till today, we do not come to a conclusive decision in the management of hepatocellular cancer. So I think we should continue our research to find a better way of optimum treatment, that is management of HCC. Otherwise, HCC will be a big problem throughout the whole world. Thank you, Professor Dr. Ghashan, Dr. Makishima, Dr. Heng Choto, and Dr. Nikhil Agrawal for your nice presentations and for also sparing your valuable times to participate in the BICC 2025. Thank you all for your patience hearing.
Thank you, Honorable Chairperson. Now we begin our memento giving ceremony. I request Professor Dr. A.M.M. Shariful Alam to present the memento to Dr. Nikhil Agrawal. Please welcome Dr. Nikhil Agrawal. Then Professor Dr. Kudrete Ilahi sir will present memento to our moderator Dr. Saiful Alam. Rest of the speakers have already received mementos in previous sessions, so we request we request Professor Dr. Kudrote Ilahi sir to receive his memento. Please give a round of applause. Thank you for your participation.
Ladies and gentlemen, there is an important announcement. We have reserved the first 3 rows of this hall for our foreign speakers, chairperson of all sessions, and specially invited guests. Thank you. Good evening, everyone. Welcome to the final scientific session on breakthrough research. We are deeply honored to introduce our distinguished chairperson of this session, Dr. Ehtishamul Haq, Senior Consultant, Clinical Oncology, Lab 8 Cancer and Super Specialty Center, and Major General Professor Dr. Muhammad Azizul Islam, ex-professor, Department of Oncology, CMH. I'd also like to invite the moderator of session, Dr. Muhammad Jahangir Alam, Department of Medical Oncology, NICRH. Now, I humbly request our Honorable Chairperson and moderator to take on the stage, and the proceeding will be conducted by respected moderator. Thank you.
Good evening. Without any delay, I am welcoming Breakthrough Research Session 6. My first speaker, Professor Dr. Muhammad Ghulam Mustafa, Chief Consultant Pathology, Anwara Medical Services, Dhaka, Bangladesh.
Respected chairpersons and distinguished participants, for the next 10 minutes, we will try to uncover CAP. CAP? What is CAP? CAP is a heterogeneous group of disorder defined by presence of metastatic disease with no identified primary tumor at presentation. So we'll start with a case, a 62 years old woman presenting with weight loss, multiple hepatic lesions on CT scan, core biopsy from liver shows poorly differentiated malignant neoplasm, initial lab unremarkable, tumor markers non-contributory. So this is the histology, sheets of atypical cells, no glands, no pigments, that is no melanoma, no evidence of lymphoma, no squamous differentiation. So what will be our step, or how we'll come to conclusions? So our first step is morphology, differentiate types of cancer, whether it is carcinoma or lymphoma or melanoma or sarcoma. So morphology can tell us a good information. This is a gland-forming tumor, so it is adenocarcinoma. And this is lymphoma, and this is sarcoma, spindle cell tumor, so it is sarcoma. So morphology can play an important role. Now this is an adenocarcinoma. On the left side, it is well differentiated adenocarcinoma. On the right side, it is poorly differentiated adenocarcinoma. And this one is squamous cell carcinoma. There is evidence of keratinization. And this is a small cell neuroendocrine carcinoma, very cellular tumor. So the next step is confirming cell lineage. So morphology can provide some clue about cell lineage, but the key player is immunohistochemistry, which can determine cell lineage. For epithelial phenotype, pancytokeratin. For hematolymphoid, CD45 or LCA. For melanoma, S100, Melan A, SOX10, at least S100 and HMB45. And if all three are negative, then we'll have to think about mesenchymal tumor or sarcoma. But unfortunately, there is no single marker for sarcoma. So we have to consider at least desmin, SMA, and vimentin. Next, mesothelioma, and its marker is calretinine. Germ cell tumor is common marker is sulfur, and neuroendocrine, we know synaptophysin and chromogranin. So, for establishing a carcinoma, we have to see whether pancytokeratin is positive or not. So, pancytokeratin is positive, then CD45 is negative, and S100 is negative. So, CD45 negative means it excludes lymphoma, S100 negative, it excludes melanoma, desmin negative, it excludes myogenic sarcoma. So, third step is identification of tumor subtype. So, if you see this chart, 60% of the carcinoma of unknown primary cases are well to moderately differentiated adenocarcinoma. And another 29% is poorly differentiated carcinoma. So about 90% cases are adenocarcinoma. 5% are squamous cell carcinoma, another 5% undifferentiated neoplasm, 1% is neuroendocrine tumor. So next we have to differentiate the primary. So for breast we use GETA3, for lung we use TTF1 and nepsin. For GI and pancreatobiliary we use CDX2, CA19.9, and for Mullary and Pax8. So in this particular case, EMA was positive, P63 was negative. Now the step 4 or next step is primary localization. And this is the key player, this chart. So we have to depend upon CK7 and CK20. So if CK7 is negative and CK20 is positive, straightforward it is colorectal. And if CK7 is positive and CK20 is negative, it is above diaphragm, and below diaphragm only papillary renal cell carcinoma, ovarian serous carcinoma, endometrial carcinoma, and endocervical carcinoma. If both are positive, CK7 and CK20, it is stomach, biliary tree, pancreatic duct, mucinous, ovarian, and urothelium. And if both are negative, then it is liver, adrenal cortex, renal clear cell tumor, prostate, and non-seminamatous germ cell tumor. So GETA3 negative, CDX2 negative, Pax8 negative, and this is TTF1. TTF1 is positive. CA19.9 was positive. So in this particular case, whether it is breast is not breast because GETA3 is negative, TTF1 is positive, CDX2 was negative, but CA19.9 is positive, and Pax8 is negative. So it is primary lung adenocarcinoma. TTF1 is positive, and although CA19.9 was positive, but we are not considering pancreatobiliary because CA19.9 can be positive in some lung adenocarcinoma. And another point is TTF1 can be positive in thyroid carcinoma also. So this is the difference among lung adenocarcinoma, pancreatobiliary adenocarcinoma, and thyroid carcinoma. So our case morphology was poorly differentiated. The pancytokeratin positive, So it was epithelial, and it was CK7 positive, CK19, CK20 negative. So it is either adenocarcinoma of lung or breast, upper GI or Mullerian, and as TTF1 positive, so it is lung primary. Now, about molecular advances. So why we do molecular test? Molecular test we do to see if there is any actionable driver mutation. So there are now different methods. We can do molecular test. We can do next generation sequencing. So in case of CAP, what actually happens? What occurs to the primary tumor? So many primary tumor remain diminutive and thus escape the initial detection. It may disappear after seeding the metastasis. And it may be contained or has been eliminated by the body's defense. So these are this one is a malignant small round cell tumor, and CD99 is positive, FLI1 is positive, so it is EU sarcoma. So CAP is about 3 to 5% of the total tumors. Fourth most common cause of cancer-related death. Incidence increases with age and is higher in men compared with women. Probability of survival after a diagnosis of CAP is about 20% at first year, and median survival is 3 months. Often presents with early metastasis and poor prognosis. And diagnostic challenge, treatment delay, and limited target options. So histopathological diagnostic goal for CAPs, first is to confirm malignancy. Next, to exclude highly treatable cancers like lymphoma, germ cell tumor, then predict tissue of origin where possible, and guide targeted therapy when feasible. So thank you very much for your patient hearing.
Thank you, Professor Dr. Mohammad Ghulam Mustafa. Now I would like to request Professor Dr. Jannatul Firdaus, Chairman, Department of Gynecological Oncology, Bangladesh Medical University.
Assalamu alaikum. Good evening to all of you. Welcome to my presentation on comparative study between HPV-6E7 mRNA test and HPV DNA test in detecting cervical precancer. I have nothing to disclose, and the next 10 minutes I will talk on socio-demographic profile of Bangladesh, burden of cervical cancer in Bangladesh, screening options available, why novel screening strategy is required, study results and recommendations. So population in Bangladesh is around 200 million. Bangladesh reached the lower middle income country status in 2015. GDP per capita income is around $2,000 US. 21.8% of people are below the poverty line. Male to female ratio 96.7 males per 100 females. Bangladesh has a population of around 64 million women ages 15 years and older who are at risk of developing cervical cancer. Bangladesh, like other developing countries, faces a burden of disease due to lack of adequate screening and a high prevalence of the other risk factors for development of cervical cancer. It is the second leading cause of cancer death in women in Bangladesh. So we also align with the 90-70-90 targets of WHO, and in the second pillar, that is 70% women screened with a high performance test or high precision test should be recommended by WHO at age 35 and 45 years of age. And today my topic is on this one of the high precision tests. Now, in Bangladesh, actually, all the screening options are available like pap smear, LBC, VIA with their own sensitivity and specificity. And the pilot study on HPV DNA testing is going on, and the interim report is also very good. But there are certain challenges in the screening because there are barriers to cervical cancer screening, like challenges in sustainability of the screening program, challenges in treatment of cervical precancer, and also challenges in hard-to-reach area. Our target population is currently 13 million, but the coverage is only below 20%. For this reason, it is critical to understand the molecular events of cervical carcinogenesis and to establish and implement a novel test that will be more specific. If we look at the oncogenic pathway by HPV, actually HPV DNA has 3 functional regions, and among them the early genes are responsible for the active viral replication and proliferation. By the process of transcription, the information in E6 and E7 gene is copied into a new molecule of mRNA, and by the process of translation, this E6 and E7 from the information, E6 and E7 oncoproteins are synthesized that interfere with the activity of tumor suppressor protein that leads to cell cycle dysregulation and cellular immortalization and start the process of carcinogenesis. E6 and E7 are the only viral genes that are always retained and expressed in HPV positive cancer cells. Recently, WHO has also recommended to do HPV E6, E7 mRNA test as a method of primary method of cervical cancer screening. On the basis of this background, the study was performed to compare HPV E6, E7 mRNA test with HPV DNA test in detecting cervical precancer among VIA positive women. The study was a cross-sectional analytical study which was performed in our national center among 264 VIA positive women, and HPV DNA test and mRNA test, both the tests were performed among all the participants, and also colposcopy and biopsy was performed. HPV DNA was done in COBAS 4800 platform, and HPV mRNA was tested by using PCR method, and histopathology was regarded as the gold standard or reference standard. If we look at the results regarding demographics, majority of participants were between 31 to 50 years, with the largest group in 31 to 40 years. And HPV DNA was detected in 34.47%, whereas mRNA positivity was in 28.79% among the study participants. Regarding the histopathology, we found that chronic cervicitis was the most. It was 61.7% cases, followed by CIN3, CIN1, 2, AIS, and in 2.3% cases, squamous cell carcinoma was found. So actually, in 17.8% tested positive for HPV DNA and 3% for HPV mRNA in the chronic cervicitis cases. That means in chronic cervicitis cases, DNA positivity was more, but whereas the mRNA was less in this group of participants. If we look at the diagnostic test results in CIN and cancer, mRNA positivity rates were higher than DNA in case of CIN2, 3, AIS, or CIS and squamous cell carcinoma, whereas DNA was higher in CIN1. This is an interesting table showing age-specific distribution of HPV DNA and mRNA positivity. DNA and mRNA positivity were highest among the older age group, that is 51 to 60 years age group, whereas DNA positivity was more in the younger age group, that is 25 to 30 years age group. And if we look at the diagnostic performance of HPV DNA versus mRNA, then mRNA consistently showed higher sensitivity, specificity, and accuracy than DNA across all disease categories. Similarly, mRNA demonstrated higher Uden index values in all categories, highlighting superior diagnostic performance than DNA. And the table is also showing that the moderate agreement was observed between the two tests. So the core findings of this study was mRNA had higher specificity that leads to fewer false positive results and stronger correlation with the disease severity. Sensitivity for squamous cell carcinoma was 100%. For CIN2, it was 93%, CIN3 73%. But DNA frequently positive in the benign lesions, like in case of chronic cervicitis, 17.8% cases DNA was positive. If we look at the biological significance of this study result, then we can say that HPV DNA detects both transient and persistent infection. E6, E7 mRNA reflect oncogenic activity which drive the carcinogenesis. And this explains higher accuracy in detecting high-grade lesions by mRNA. And this result is also supported by Athena trial. Regarding clinical and public health implications, the results of this study, actually, if we look at the result of this study, DNA false positive is more that lead to unnecessary stress, unnecessary colposcopy, and that leads to a burden on the resources. Whereas mRNA optimizes healthcare resource allocation. It maintains high specificity for CIN2 plus lesions while reducing over-treatment. And the result also aligned with WHO 2021 recommendations. So regarding the comparative global perspective, international evidence shows that mRNA consistently more specific. The findings of this study in Bangladesh study also align with the global data. And so integration of mRNA into the national program could enhance screening efficiency, and it has a strong potential in low resource settings. There is certain limitations in this study, like it was a single-centered cross-sectional study performed only in the VIA positive cases, so the larger multi-center longitudinal studies are required. In conclusion, HPV E6 and E7 mRNA is superior to DNA in specificity, in accuracy, and the predictive value. It prevents unnecessary colposcopy or over-treatment. Especially, this test is valuable in the low-resource setting, as the cost of HPV DNA test and HPV mRNA test will not have an same, so it will not have an extra economic burden. I like to give thanks to BMU staff, our participants, and this study is actually funded by partially funded for the PhD program, our national center, also thanks to Department of Virology and my supervisor and co-supervisor. So thank you all for patience hearing.
Thank you, Professor Dr. Jannatul Firdaus. Now I would like to request Professor Dr. Sarwar Alam, Professor and ex-Head of Medical Oncology, Bangladesh Medical University.
Assalamu alaikum and good evening to every audience. This is very simple observation but very significant. It's a cross-section study on the survey on the prescription pattern of osimertinib among non-small cell lung cancer patients in Bangladesh. This is the number of participants and discipline. Number of oncologists is 112, and it is very important that in our country, this is near about 250 to 300 oncologists, so it is near about 40% of all oncologists in Bangladesh. It is very interesting that osimertinib is prescribed by mainly professors, senior consultant and consultant, but a significant amount of doctors and specialists of junior level like registrar, assistant registrar and medical also prescribe osimertinib. And this is very interesting that the osimertinib, though it is a MTT and selective drug, but it is very interesting that in our oncologists in remote places like Dinajpur, like Kumilla and Noakhali, they also prescribe osimertinib. The background of this operation is because osimertinib is third generation and irreversible epidermal growth factor receptor tyrosine kinase inhibitor, has demonstrated clinical and particularly in CNS metastasis. As I also learned from our previous session, globally, one of the highest prescribed molecule, everyone is known. In last 6 years, osimertinib has been in the first line of non-small cell lung cancer treatment option in the all guidelines, particularly metastatic non-small cell lung cancer. Objectives of this study is very interesting to determine the prescribing pattern in terms of osimertinib decision making and preferred settings, frequency of EGFR mutation positive cases and treatment pattern, adverse effects following treatment and management pattern, progression-free survival in months following the therapy, and management pattern of osimertinib failure and resistance cases. As I mentioned, about 112 oncologists working in different hospitals and private centers from all over Bangladesh who had experience in treating lung cancer patients and in prescribing osimertinib. The survey is done by Kobo Collect Toolbox, an open source field data collection instrument. The questionnaire is prepared using the Kobo Toolbox according to the study objectives. Collected data is analyzed and compiled. Statistical data analysis is done by SPSS. Our question, number one question was, what is the types of lung cancer to the oncologist? So clearly it is non-small cell lung cancer in all cases. Setting of the prescribing osimertinib. Osimertinib was recommended in 8% in the adjuvant setting, 14% in metastatic setting, and 77% in both adjuvant and metastatic setting for patients with non-small cell lung cancer. Decision making for the prescribing osimertinib, this is very important slide. 41% prescribed osimertinib based on the EGFR mutation de novo. Patient, when advised, they did EGFR mutation study. But 5% is prescribed empirically. That is very significant. And it is correlated in our peripheral oncology centers where facilities of molecular study is not available. And another interesting findings is that 52% prescribed it is empirically or through the EGFR mutation analysis, depending on the patient's financial response. As because we are a low incoming countries, we have to ask to do EGFR mutation study because of it is availability and the costing. EGFR positive cases in last 6 months. 43% of practitioners identify EGFR positive cases between 0 to 20%. 42% of them, that is our oncologist, they found EGFR mutation is between 20 to 40%. And 7% observed that the positivity is 40 to 60%. And 9%, about 9% observed between 60 to 80%. choice of first-line treatment in regimen of EGFR positive. We all, everyone are now known to us that in metastatic setting, the osimertinib with or without chemotherapy, this is the category 1 choice. In our oncologist, for EGFR positive mutation cases, osimertinib and chemotherapy combination was prescribed 58%. 58%. Osimertinib was only osimertinib was 23%, and other MPTs of first generation, erlotinib or gefitinib was prescribed by 88%. Only chemotherapy was chosen by 6%, and 2% of them went for immunotherapy. And regarding adverse effect, most of the oncologists, that is 94% practitioners, encountered no significant incidence of adverse effect. Only 5% oncologists observed some adverse effect. Types of adverse events. The interesting parameters is that the most commonly GI tract toxicity like diarrhea, mucositis, and other events, and new onset of hypertension. And another observation is that hand-foot syndrome, though it is uncommon in osimertinib, but as because there is a common side effect in skin problems like dermatitis, dry skin, irritation, pruritus, hand-foot syndrome is occasionally occurred. Then another observation by oncologist is progression-free survival. 42% of practitioners observed 6 to 12 months PFS, that is progression-free survival, after prescription osimertinib. 38% identified 12 to 18 months progression-free survival, and 10% found more than 18 months, and only 8% observed 2 to 6 month progression-free survival. Resistance against osimertinib. 72% practitioners detected no resistance or failure cases against osimertinib. That is very important. And 25% of the oncologists discovered resistance or progression of the disease. And management approaches of osimertinib resistance or failure cases or progression of the disease, according to the result, 50% of practitioners repeated the EGFR mutation test, 17% practitioners prescribed platinum doublet chemotherapy with monoclonal antibodies, and 3% of them prescribed platinum doublet chemotherapy with other TKS. 3% of the preferred increasing of the doses of osimertinib, and 25% used alternative strategies to treat cases of osimertinib resistance or failure. Other specific methods to manage osimertinib resistance failure, 18% practitioners prescribed only chemotherapy, and other reported approaches were erlotinib, nivolumab like immunotherapy, and newer third generation lazertinib and pembrolizumab. Radiotherapy and some cases individual approaches also done. In conclusion, it is observed that in also our peripheral regions, the oncologists are prescribing osimertinib, and a lot of oncologists prefer osimertinib plus minus chemotherapy. And according to the survey, osimertinib was found to be tolerated with minimum adverse effects. However, progression-free survival varied widely from 6 to 18 months. Research on a larger scale is suggested to generating more specific and evidence-based data in practical settings. Thank you all.
Thank you, Professor Dr. Sarwar Alam. Before my next speaker, I request you all, please keep silence. Please keep silence. Now I request Professor Dr. Alamgir Kabir, Professor, Department of Hematology, Bangladesh Medical College Hospital.
Thank you. Assalamu alaikum. Good evening. I started my topic is the establishing a hematological ward in a private medical college. There are about 70 private medical colleges. There is no hematology department. I joined in Bangladesh Medical College, and there is very much burden with the hematological disorders and non-hematological malignant disorders. Establishing a hematology department is a very complex and critical undertaking for a hospital. It requires careful planning, significant investment, and clear vision. This comprehensive guide to establish a hematology department, strategic planning and vision, this is a foundational phase that dictates all subsequent decisions. And the services includes the basic and general hospitals and the tertiary level hospitals. That is, they are the diagnostic hematology, clinical hematology, hemato-oncology, with all sorts of immunotherapy, chemotherapy are necessary. Hemostasis and thrombosis unit is also necessary in our country, in every private and public hospital, to serve the surgical wards and medicine ward. The laboratory design. This is the pre-analytic area, analytic area, and post-analytic area. Among support areas, so there is a laboratory information system, IT server system, waste disposal, all are necessary to establish the laboratory design. Then equipments and technology. It is a core laboratory equipments, core laboratory and specialized equipments. Specialized equipments means the flow cytometry, PCR and real-time PCR, next generation sequencing for platform of comprehensive gene profiling, apheresis machines, blood bank refrigerators, and liquid nitrogen tanks for the stem cells preservation if bone marrow is done. IT infrastructure, hospital information system, and laboratory information system integrations, and picture archiving and computerized system for digital morphological images. Human resources. The core team, a multidisciplinary team is essential. That is the medical staff, there's a clinical hematologist, and laboratory staff, there's a scientist, and the supporting and nursing staff, so that is both BMT coordinators of nurses and social workers and dietitians and psychologists. protocol and procedures and quality management. This is the development of the standard operating procedures, transfusion policies and massive transfusions policies. Implement a quality management system, internal quality control, external quality assessment and accreditation from the CAB, Joint Commissioner International and ISO. And clinical pathways and guidelines from NCC and ESMO and ASH for common outlines. Operational launch and growth start with the core laboratory and outpatient services, then a BMT unit is typically then final most complex addition. Research and academic integrations to become summary of key success factors, that is a strong leadership, adequate funding, skilled multidisciplinary team and robust technology and uncompromised quality and safety and integrations. Global aspect of hematology development is a historical slide. The mid-20th century, UK developed hematology from separation from the pathology. In 1934, the Hammersmith Hospital first organized hematology lab, and the cool counter in 1960 is a milestone for hematology development. Our Professor M.A. Rashid, he is the father of hematology in Bangladesh, worked as a registrar in the Hammersmith Hospital. And we also remembrance with tributes our two hematologists. One is Professor Monoarul, who is died due to Madrid. He makes the hematology vibrant. And another Professor, Dr. Abu Yusuf, he is one of the front-line worker for hematology in CMS, which is the topmost good center in Bangladesh now. Hematology in USA in 1955, ASH development is the milestone for hematology development in USA. Hematology in Bangladesh. In 1979, Professor M.A. Rashid established in, at that time, IPGMR, now Bangladesh Medical University. Now our dream is the reality. We have 10 BMT centers. This is one of the breakthrough of treatment of hematological malignancy in Bangladesh. And our next target is CAR T-cell therapy. Then what is the situations of the Bangladesh Medical College Hospital, where I joined in 2022. There is in internal medicine infrastructure, 1 chief consultant and 3 younger doctors. And since 2022, I have a observational study. The sampling is a cluster sampling. Cluster sampling means if the different institutes, one city, this is Dhaka Medical College, Bangladesh Medical University, and CMH, and then the Bangladesh Medical College Hospital. And we found CML and AML and the non-Hodgkin's lymphoma is the public health concern. Specialized outdoors for OPD and challenges. The financial challenges, this is the most common challenges. Then scarcity of the specialized talents and the high demand for technologists. Technology infrastructure challenges, operational and quality assurances challenges, and the mitigations of the studies, the phase development and strong leadership strategic partnership, investment in people, and meticulous financial. In summary, the challenges of establishment a hematology department are significant and multifaceted, requiring not just financial investment but strategic foresightness, resilience, and unwavering commitment to quality and patient's care. I think I am Professor Alamgir Kobir is the Chief Consultant of Bangladesh Medical College. I request my three doctors to stand up to see the audience, how they work from 22 with us to make a big job, for the research and development purposes of this study. Thank you all. Thank you all.
Thank you, Professor Dr. Alamgir Kabir. Now, Dr. Sabina Karim. I would like to request Dr. Sabina Karim, Associate Professor, Pediatric Hematology and Oncology, National Institute of Cancer Research and Hospital.
Assalamu alaikum and very good evening to learned audience and respected panelists. I am Dr. Sabina Karim, Associate Professor working in the Department of Pediatric Hematology Oncology at National Institute of Cancer Research and Hospital. So, my topic is mortality patterns among hospitalized pediatric cancer patients, a 5-year retrospective study at a tertiary care cancer hospital. So, we all know that though 4 lakh children diagnosed with cancer every year and childhood malignancy is highly curable, comparing to total cancer burden, it represents only 2 to 5% in some countries. And if we consider when we lost a child, the potential life years lost, it is the 4th most important malignancy after lung, breast and colorectal cancers. And childhood malignancy is highly curable and biology of childhood malignancy differs significantly from adult malignancy. Unfortunately, about 43% to 50% of children remain undiagnosed before diagnosis and registration, and most of them succumb to their cancer before getting appropriate treatment. Consequently, there are gaps in information concerning the incidence and mortality of childhood cancer in low and middle income countries. So it is a devastating fact that the children are the future of every nation, and every 3 minutes a child dies of cancer. Out of 80% of them can be saved with appropriate treatment. And 80% of children with cancer live in low and middle income countries, and it is unfortunate that 80% of childhood cancer deaths occur in low and middle income country. So 1 in 5 children who are diagnosed with childhood cancer will die, and 1/3 to 1/2 of these patients die in hospital. So, and there is no study in Bangladesh, also most of the low and middle income countries, also in high income countries on death, but survival statistics are available most of the countries. And with a substantial minority of pediatric cancer patients die in the ICU setting. So what is treatment related mortality? Previously we called it early toxic or induction related death, and in 2015 it was defined as death occurring in absence of progressive cancer. And treatment related mortality in high income countries 3 to 5%, but treatment related mortality in low and middle income countries data are not available, and it depends on the disease. That is, CNS malignancies it is high, in hematological malignancies it is also high. So to save the 1 million more lives, WHO has taken an initiative in 2018 to reach, increase the survival rate up to 60% by 2030. So what is the aim of the global initiative for childhood cancer? To increase prioritization of childhood cancer through awareness building at global and national levels, and to deliver best practice in childhood cancer care. They selected 6 index cancer, which is highly curable, more than 90% in developing world, but 30 to 20% in our setup. So I work in National Institute of Cancer Research and Hospital, which is a 300-bedded hospital with radiotherapy facilities. So my department, there are 10 qualified pediatric hematologists and oncologists, and 2 radiation oncologists are working. We have allocated 40 beds, 15 for hematological malignancy, 25 for solid tumor, because solid tumor patients are selectively referred here. So we have done baseline study to see the how much patients we are dealing with. In 2014 to 2019, 3,108 new cases come to our department, and malignant bone tumor and retinoblastoma was the commonest malignancy in our setup. So we have also done one survival study from January 2016 to December 2020, which showed that our survival rate is 36.4%, though we could not trace half of the patient over telephone or other procedures. So survival study shows that malignant bone tumor, soft tissue sarcoma and CNS tumor survival rate is higher at NICRH, which is not the real scenario. Actually, acute lymphoblastic leukemia, Burkitt lymphoma, hematological malignancies are highly curable in children, and nephroblastoma and retinoblastoma is also highly curable. This is due to selective referral of solid tumors in our institute. So we deal with around 800 to 1,000 new cases per year. So why I am talking about death? We have baseline data about new patients, about survival statistics, but no data about death. Why death audit is important? To identify contributing factors to childhood death, provide essential data to guide quality improvement initiatives, and prevent avoidable deaths and strengthen healthcare systems. So our result, it was conducted in the Department of Cancer Epidemiology, Management Information System, and data was retrieved from the death files kept in the MIS. And we have total 235 deaths over 5-year period, and this is the male-female ratio. And hematological malignancy and solid tumor deaths were almost same. It is 50-50. And our results showed that 10 to 49, 14.9 years age group was the commonest age group who died during the study period. So year-wise distribution shows that 10 to 15.9 years was the commonest age group whom we lost during hospital stay. And this slide shows that the year-wise distribution of patient, if we look at 2022, 23 and 24, our death rate is almost same. So if we compare the child we lost are GICC index cancer and other cancers, we see that total 121 patients died of GICC index cancer and total 114 children died of solid tumors. So year-wise distribution of patients according to type of malignancy, the blue bar is hematological malignancy, the orange bar is solid tumor. We see that hematological malignancy cases are increasing day by day, and solid tumor referral is decreasing day by day. So profile of GICC index cancer in comparison to other cancers, we see that our ratio is 50, almost same in our hospital. So what is the duration of hospital stay? During the death period, we see that most of the patients, around 121, 51% stayed in hospital for 7 days, and 75% stayed 8 to 14 days. So what are the situation in other low and middle income countries? This is a study done in Johannesburg, South Africa, and the blue bar represents the disease progression and orange bar represents the relapse. In their country, disease progression and relapse rather than treatment mortality contributing to death more than treatment related mortality. So mortality profile in India, 11-year retrospective study was done from 2007 to 2017, which shows 50% death from hematological malignancies. So early death from childhood cancer is defined as first 30 days. It is 7.5% deaths of pediatric cancer. If you look at the blue bar, we see that CNS tumors mostly died of disease progression, and in the second strata, if we see that green bar, hematologic malignancies mostly died of infection. And this study was done in pediatric neurology at Sick Kids Hospital, Canada. They showed that progressive disease, that is 94% of CNS tumor died of progressive disease, and CNS tumor is the most common solid tumor in children. Another study done at 69 participating hospitals in 18 low and middle income countries that shows that hospital level factors like pediatric oncology volume, structure and ICU resources are not significant risk factors for morbidity. It is important that clinical decision making, local clinical practices and hospital clinical systems are important to reduce morbidity. So our limitations are inconsistent records, inherent difficulties related to incomplete or missing data, patient record at diagnosis is not available in all records, accurate staging and disease status is not recorded. All documents during the event are not available due to lack of electronic medical record. So my key message is continuous quality improvement, ongoing collection, review and action based on local data, and we plan to do a prospective study needs to overcome the challenges in data collection. So I acknowledge the Cancer Epidemiology Department and MIS of our hospital, Dr. Johirul Islam and Dr. Nazma Azim, medical oncologist and programmer, and Professor Afiqul Islam, our guide and mentor, who guide me throughout the process. So thank you all for your patience hearing. Thanks organizers of BICC to give me the chance to talk over here. And no child should die at the dawn of life. And this is the creative activities by our children in September, which is the Childhood Cancer Awareness Month. And one child wrote that cancer mukto prithibhi chai. ওরা কোনো ইনজেকশন চায় না, কোনো ট্যাবলেট চায় না, ওরা চায় যে খেলবে, ঘুরবে, বেড়াবে, স্কুলে যাবে। Thank you all for your patience hearing again.
Thank you, Dr. Sabina Karim. Now I like to request Dr. Muhammad Mustafizur Rahman, Professor, Department of Pharmacy, Khulna University.
Assalamu alaikum. Respected chairs, moderators, and esteemed audience. I am at the very last version of this presentation, and you all are practicing oncologist. I wonder that you might have the most boring 10 minutes. So my topic is microRNA 27A deregulates human heparin binding EGF-like growth factor in ovarian carcinogenesis. So before in the evening, I was asking ChatGPT what might be the future direction of research with microRNA before going to the topics. So I found microRNA hold great promise as therapeutic agents in cancer due to their ability to regulate multiple oncogenes and tumor suppressor pathway simultaneously. This is important point. Another point is microRNA can restore and modulate cancer progression, enhance treatment response, and achieve more targeted and personalized therapy. So with this objective, I am going to introduce you about microRNA. So this is the short non-coding RNA, and they have some binding site in the 3' messenger RNA tail site, and they have target for all genes in 60% genes. And microRNA biogenesis like that, it is synthesized in the nucleus, they come out and they finally bind here, they refresh two stages, translational repression and micro mRNA cleavage. So microRNA works in two stages, mRNA degradation and translational repression. So this is cancer. In cancer, we find whatever the phenotype is, there should be some genotypic sense. So genotyping says this is normal cells, DNA repair genes are down-regulated, tumor suppressor genes are down-regulated, onco genes are up-regulated. So all three things will happen, or part of these three things will happen. And finally, we will get malignant cells. My question is, what about microRNA in the cells? So if microRNA is up-regulated, in tumor cells, microRNA upregulation occurs and tumor suppressor gene downregulation occurs. And in tumor cells, if microRNA is downregulated, the oncogene expression will be promoted. And finally, in ovarian cancer, this is the most lethal of the human female cancers, which there is no reliable screening test. And HBEGF, this is a human heparin binding EGF-like growth factor. This is a gene that is responsible. This is an oncogene. It is responsible for oncogenesis in ovarian cancer, and this is the biology of this gene. I will skip this one. And our hypothesis is microRNA might play potential role in ovarian carcinogenesis by targeting HBEGF gene and modulating its expression. So our objective is like that, to find out the candidate notorious microRNA that binds with HBEGF and investigate the functional role of candidate microRNA that deregulates the HBEGF in ovarian carcinogenesis, and find out the therapeutic potential of the candidate microRNA. For that one, we use target scan and mirror-based software. We found a pool of microRNA. From that microRNA, we find out, we could carry out the screening. After screening, we get candidate microRNA and then carried out functional analysis. So we get 11 microRNA that were supposed to bind with target HBEGF, this gene. Among these 11 microRNA, then we introduced ovarian cancer cells. These 3 ovarian cancer cells, this one SCOP3 MCAS. These 3 ovarian cancer cells have differential expression of HBEGF in 3 types. Then we carry out by quantitative real-time PCR, we check the expression of our targeted microRNA, and we found that in this microRNA 27A, 27B and microRNA 99A, this has reciprocal relationship with HBEGF gene. And then from there, we screened out microRNA 27A because it has reciprocal expression with HBEGF in this part. Then we targeted microRNA 27A as a more promising candidate for our HBEGF down-regulation and carcinogenesis. And here is then we check that whether this microRNA can target HBEGF by carrying out luciferase reporter assay. We check that this microRNA here, this MIR27A targets this HBEGF in that 5' UTR. And then we carried out check that microRNA expression, how it modulates the HBEGF expression in the breast ovarian cancer cells. We found microRNA 27A deregulates HBEGF by 50%. And in MCAS cells, in another type of cells, this regulation was less. So we checked from here, we selected microRNA 27A and SCOP3 cells, and then we checked that whether the mechanism by which microRNA 27A modulate HBEGF in SCOP3 or ovarian cancer cells. Here we found that there is down regulation occurs like that in mRNA level by real-time PCR, and in Western blot analysis showed in protein level. So we we could conclusion that microRNA binds deregulate ovarian HBGF in ovarian cancer cells at protein level and mRNA level. Then we carried out microRNA, how it affect the in vitro growth of ovarian cancer cells. In vitro growth, 3D collagen assay and soft agar colony formation assay. In both cases, we found that microRNA, this 27A down regulates HBGF cell number. So mRNA expression, if we increase, and that cell growth was decreased. By that, then we introduce this cell to check the in vivo assay. In vivo tumorigenic assay in biopsy node mice. Biopsy node mice is immunocompromised mice. Then from this here 1 million cells we are inoculated in this node mice, and after 7 weeks we found this type of here non-control, we found big tumor. Here also anti-microRNA big tumor, but this was microRNA overexpressing cells, and this tumor size was significantly less. We separated the tumors, we found like that. And these data we are then, we carried out dose dependence, not dose dependent, in the timeline. And timeline from we found that from this non-control and anti-mir compared to control group, microRNA 27A induced case, the tumor cell were suppressed and tumor growth was inhibited in this mice. So this gave us that microRNA 27A in vivo condition, it has the potential to inhibit the cellular growth of these ovarian cancer cells. So from here, actually after that, with my collaborator in Japan, we are also checking the phase 1 trial, but I am showing you the data of up to this part here. And then from here the take-home message is microRNA 27A acts as a tumor suppressor in ovarian cancer by directly targeting and downregulating HBGF, a key molecule that is involved in cancer cell proliferation and tumorigenesis. This finding highlights the therapeutic potential of modulating the microRNA 27A and HBGF axis as a novel strategy for ovarian cancer treatment. And microRNA, not only this microRNA, has the potential to be used as biomarker. And I hope, I expect, we will show you some data in the next year, 2026, about the use of microRNA as a biomarker of cancer, especially for some sorts of cancer detection. Thank you very much. And I would like to acknowledge TBRF, Osaka University, Khulna University. Thank you. And finally, let's fight together, and we want to fight our male and female all cancers together. Let's stand together against cancer. Thank you so much.
Thank you, Dr. Muhammad Mustafizur Rahman. Now I like to request Dr. Ehtashamul Haq, one of chairperson of this session, to put his valuable comment.
A very good evening to you all. Actually, a cultural program and dinner is waiting, so I will not take time here to discuss many things. I want to thank the organizer to giving me the privilege to be the chair of this very interesting diversified session of multiple topics discussed by the brilliant and legendary presenter here, who are very eminent in their field, especially Professor Ghulam Mustafa sir. He is the founder histopathologist in Bangladesh in the area of the oncology. He did a very job for the diagnosis of the cancer patient in Bangladesh, and today he presented very well with carcinoma unknown primary, how we can navigate treatment from diagnosis to treatment, and the help which can a pathologist be done for us. So thank you, Professor Ghulam Mustafa sir, for your night presentation. And the Second presenter, Jannatul Firdaus Madam, actually one of the legendary gyno-oncologists here. She is working on the initial screening program of cervical cancer. We know that actually by early diagnosis of the cervical cancer, we can definitely save lives and mortality and morbidity. So she shows how the specific screening program can be done with mRNA detection. But the limitations is, as is shown, that only one center it is doing. I think it should be disseminated all over the countries, and the program should be taken in account by the policymakers. And the next presenter, Dr. Sarwar, Professor Dr. Sarwar, he is also one of the legendary oncologists in Bangladesh. He actually retrospectively discussed how osimertinib, a wonderful molecule, nowadays we are using in neoadjuvant to metastatic setting of non-small cell carcinoma. But in our country, we are not using this drug as it should be. So he is actually knocking us and giving us a sense that we should use osimertinib in rational ways, as nowadays many trials showing that from the neoadjuvant to metastatic setting, it is a wonderful drug and it can help all the patients of non-small cell carcinoma which is prevalent in Bangladesh. Due to short of time, I will not discuss the presentation of the other presenter, which will discuss by my co-chairman, Professor Azizah, but I want to congratulate also Dr. Alamgir Kabir, Dr. Samina Karim for their work in establishing and monitoring a pediatric hemato-oncologist unit, which is very essential in our country. And last but not least, Dr. Mustafiz, who has shown how actually precision medicine can work in ovarian cancer also, which we are working also. Thank you, organizer, again for arranging such a nice session here. Thank you.
Now I like to request Major General Professor Dr. Muhammad Azizul Islam to put his valuable comments.
Bismillahirrahmanirrahim. Learned audience, the speakers from home and abroad, ladies and gentlemen, Assalamu alaikum. Actually, this is the last session. Many of we are waiting for something else. So even then, my co-chairman have already mentioned the presentation regarding all the 6 speakers. However, I am supposed to tell something regarding the last 3 speakers. Well, I will highlight. 4th speaker was Professor Alamgir Kabir. He is an eminent hematologist of the country. He has mentioned the capabilities of the management of the hematology in our country, and it needs a lot of improvement. We hardly have few comprehensive centers for treatment of the hematological diseases, including the chemotherapy and bone marrow transplant. So he has highlighted the problems and how to improve the management. I appreciate his thoughts, and we hope and believe we will be able to improve the management of hematology in future very soon. 5th speaker, Dr. Sabina Karim. She is an pediatric oncologist. She has also narrated very nicely the different types of childhood tumors in Bangladesh as well as other countries. In Bangladesh, according to her presentation, the childhood tumors are increasing gradually, but we should have much more facilities for the management of the childhood tumors. And this is my feelings also. Many of the children are suffering from the cancers. We must develop our different centers like the other centers of the country the last speaker, Dr. Mustafizur Rahman, I must tell he is a molecular scientist from Khulna University. He has narrated regarding the molecular science, particularly microRNA 27 is one of the important molecule which is responsible for the development of the different type of cancer, but he has mentioned that it has a very important role in the development of the ovarian cancer, and in future we will be able to learn much more from his presentation in the next time. Finally, I convey thanks to the BICC authority for inviting me in this session, and I congratulate all the speakers for their outstanding presentation. Thank you very much.
Thank you, sir, for your insightful remarks. Now for the memento giving ceremony. We request our chairpersons to present mementos to the speakers and moderators as I announce their name one by one. Please welcome Professor Dr. Muhammad Ghulam Mustafa, Professor Dr. Jannatul Firdaus, Professor Dr. Sarar Alam, Professor Dr. Alamgir Kobir, Dr. Sabina Karim, and Dr. Muhammad Mustafizur Rahman. Finally, our moderator, Dr. Muhammad Jahangir Alam, will receive his memento from our chairpersons. Before we close this inspiring day of science, let us capture a lasting memory. I request all 6 speakers, the moderator, and both chairpersons to kindly gather at the center of this stage for a group photograph. As the curtains fall on 2 transformative days of breakthroughs and bonds at BICC 2025, let's carry this fire forward to defeat cancer together. Thank you and goodbye from your anchor. I am Dr. Ibnul, signing off with hope and gratitude.
So as declared, here is the second 2 winners for the iPad for the challenge, the attention winners. So due to the time shortage, I am just giving 1 minute time to prepare yourselves for this Mentimeter competition. 1 minute time. Please be ready, scan the code over there and ready for the attention challenge.